Hello and welcome everyone to the SFM Kerala meet. I know we are supposed to not have a virtual meeting, but there is no other option for us to meet online. And if you saw the beginning of our sponsor video, that's what you're missing out on, those beautiful waterfalls in beautiful Kochi. And I hope next year all of you can come and we can have a real meeting rather than a virtual meeting. But till then, welcome all. And let's start off this meeting with the welcome address from my boss, my mentor, and a person who can stake claim to the throne of being the person who started fetal medicine in the state. And it's a great honor and privilege to have Gopinathan sir here with us, and he will be welcoming us all. Sir, please.
We are going to have the first SFM meet of Kerala Society. As a president, probably a lifetime president, I can say. I was the founder president. There is no competition for me. I am continuing as the president even after 8 or 9 years. I think it is my duty to welcome all the faculties to this meeting. And actually, I am really proud and honored that leaders of the profession, our SFM society is leading the show, especially Dr. Suresh, Dr. Ashok Rana, and Murthy. I'm not seeing him here. Dr. Arun, and remaining all my colleagues are, I can see Pratibha. I think I have met her long back, somewhere on railway station or airport. And I really sincerely welcome to this meeting. And I'm just like what Bijoy told, no, we are not having physically meeting each other. But one good thing what have happened during this time, we are having a lot of webinars. Really, we are getting more and more knowledge compared to previous days. That before we had no time to really read or to attend webinar. If at all we go for some webinar, you attend one or two meetings, you go out for purchase or some marketing show. But here, at least 1 or 2 hours, what we get during this webinar, you sit and really attend to it, and we are getting a lot of knowledge within this last 1 year, and we sincerely hope this bad time will go within 1 or 2 months, and this whatever knowledge we have acquired, we will be able to really use it from next year onwards. And once more, I welcome all of you to this show. Thank you very much. And once more, thanking all the seniors and who are attending, doing this seminar. Thank you. Jyoti.
Thank you, sir, for those words. Any SFM meet is not complete without the Midas touch by Khurana, sir. The person who revolutionized the way we look at fetal medicine right now. Now, fetal medicine is like a place where everyone from every specialty can come and try to do things for the fetus. And so before we start off, a few words from you, sir. Khurana, sir, if you could just bring in that touch that you always do.
Thank you, Bijoy. That is so kind. And what I truly miss today is actually being in Kerala for this meet. But I think that we have such stalwarts from within the state, very young, very medium, as well as very senior. I really look forward to this fantastic new format that we have created, that someone will present and then equals will then discuss, and then we will do this. And I really admire the fact that you chose something called equipoise. I didn't expect that we would actually pick up controversy and put it through on a webinar, because you normally expect that, okay, everybody says yes to everybody else. But here we're going to argue, we're going to come to a conclusion. We are time bound, and yet we will come up with answers. Thank you for this brilliant idea, and my congratulations to the Kerala team for taking this forward.
Thank you, sir. And Praveen, sir, a few words before we start off. Just before we start off, a little bit of inspiration from you as well. I think you mute. Hello? Yes, we can hear you, sir. Hello? Hello? We can hear you, sir.
Yeah, I didn't hear you. Sorry.
No, we were just saying a few words
Anyway,
from you, sir, before we start off.
with stalwarts like Dr. Gopinath and Dr. Ashok talking to us and then inviting all of us. And as everyone said, as Gopinath sir said, that it's wonderful that we are meeting. And most important thing is on a working day, like a Thursday, would you ever imagine to go and virtually have a meeting? It would not have happened at all. But this is possible now. So I think we have to make best use of it. And thank you, Bijoy, as well as Meenu, for organizing such a wonderful, wonderful event. I think we all are going to be enlightened with the various topics which you choose, which are going to be of use in our day-to-day practice. Thank you, Bijoy.
Thank you, sir. And let's start off with the meeting. And the basic theme of this meeting is to break clinical equipoise. Equipoise is just a fancy term to say we don't know. When we are confronted with certain clinical situations in fetal medicine, we don't have enough clinical evidence to guide us on our management. And the 4 cases that we have chosen today for the panel discussion are essentially that. The first one being late onset IUGR, where we are not sure when to deliver these babies. Stage 1 TTTS, where we are not sure whether we should intervene or not intervene. Agenesis of corpus callosum, how to counsel these patients when we find nothing else on the scan, isolated agenesis of corpus callosum. And screening, what to do with the intermediate risk group, where there is a possibility of Down syndrome and you have NIPT, which can help you in solving that question. So without wasting further time, we go to the first panel discussion. And the flow will be such that first there will be a presenter who will present the case from his or her institute. And then the moderator will take over and discuss the case with the help of the panelists. And hopefully we may be able to reach to some conclusion, although I am sure that there will be certain amount of argument, because equipoise is always going to be equipoise unless we have clinical evidence to prove otherwise. So let me start off by asking Parvati, who is the senior consultant at our hospital, to start off with her case on late onset growth restriction. And after that, I request Praveen sir to continue and moderate the session. Parvati, please. Can you unmute your mic, Parvati? We can see you. Can you share your screen? Can you?
She's from Sima Fertility Center. I'll just make her the host. Give me a second.
Yeah. I think you made her host.
Shivam, make Sima Fertility Center as the host.
Okay. Just wait, Parvati.
Yeah. Unmute and then. Fine. Good. I think you have to maximize the screen.
Just put slideshow.
Slideshow.
Yeah.
No, I think.
Okay, very good evening to all. So let us start with the first case for today. So I'm presenting a 38-year-old, gravida 2, abortion 1, ICSI conception, donor embryo transfer. She's a known hypothyroid and GDM on diet with a family history of diabetes and hypertension. She's a booked case at our center with last menstrual period on 20th of May 2019. The early pregnancy scan done at 8 weeks 4 days showed CRL corresponding. NT scan was also normal with normal NT, DV and nasal bone, and uterine PI was also normal. She did not opt for a screening test. So in view of high-risk nature of pregnancy, she had moved to the 12th centile. Amniotic fluid index was 9.5 and she continued to be normotensive and euglycemic. This is a spectral Doppler trace. Now here the graph shows a small rise in the umbilical artery PI and the fall in the MCA PI. CPR was at the 7th centile. 35 weeks, a CTG was repeated, which showed a reactive trace with good accelerations and beat-to-beat variability. At 36 weeks, growth scan was repeated and we found that AC had fallen to the 14th centile and EFW to the 3rd centile. So we looked into the Dopplers. This is again the growth chart showing slump in the AC and the EFW centiles. Now, when we looked at the Dopplers, we found that the umbilical artery PI was 1.17, which showed resistance. MCA was at the 17th centile. CPR had fallen to the 2nd centile. This is again the graph showing rising trend in the umbilical artery PI and fall in the MCA PI. CPR at the 2nd centile. Still, we were reassured because the BPP showed good breathing movement. Amniotic fluid index was 8 centimeters. So a closer surveillance was done. So after 3 days, a CTG was repeated, which showed a flat trace with no heart rate variability and no fetal movements perceived. We repeated the CTG after 1 hour, which showed an unprovoked deceleration. Hence, she was taken up for emergency section, indication being late onset IUGR with non-reactive CTG. She delivered a male baby, 1.8 kg. Baby cried immediately after birth, and the UGR was 8/9. Umbilical artery pH was 7.3. Baby did not need any NICU admission. So to summarize, my patient conceived by ICSI conception, diabetic control with diet. First trimester scan was normal. All growth parameters were corresponding to the 50th centile up to 28 weeks of gestation. At 33 weeks, the CTG was reactive. At 34 weeks, interval growth was satisfactory with improvement in the estimated fetal weight and AC centiles, amniotic fluid index of 9.5, but Dopplers showed decline in the MCA and the CPR centiles. 35 weeks, the CTG was again reactive. At 36 weeks, there was decline in the EFW to the 3rd centile, and Dopplers showed umbilical artery resistance with CPR at the 2nd centile and amniotic fluid index 8 centimeter. BPP showed breathing movement. CTG was again repeated at 36 week 3 days, which showed initially no heart rate variability, and when repeated 1 hour later showed deceleration. So emergency section done for fetal distress. UGR was 8/9 and umbilical artery pH was normal. So that's all with the case presentation. Over to you, Dr. Praveen, sir.
Thank you, Dr. Parvati. I think it was a wonderful case presentation, and actually you choose a very appropriate case. First and foremost thing, I really congratulate you for taking up this case and at the same time doing a proper assessment of the fetus. This is how I think we need to go about. The first and foremost thing, as she has identified that there is some amount of fetal, late onset fetal growth restriction from 32 weeks onwards, where she followed up with an interval scan, which showed that there was some improvement in the interval scan, interval growth, but then the Dopplers were falling down. Another most important thing which we have to learn from this case is that she has plotted every parameter onto the graph, which makes our life much, much comfortable. In the sense, the moment you see the graph, you can appreciate whether there is a decline or whether there is a increase in the percentiles. So both the growth parameters as well as the Doppler parameters were plotted on the graphs, which made us suspect that there is a problem of Dopplers or hemodynamic variation that is taking place. And another important factor which we should understand from this particular presentation is that the BPP, they have taken the biophysical profile, particularly depending on the fetal breathing movements, which is one of the most important parameters as far as the late onset growth restriction is concerned. And based on that, as well as the CTG, which has of late, that is at about 36 and 36 weeks, 3 days, what happened was that there is, initially there was no heart rate variability, but then there was deceleration, which prompted them to do a cesarean section for the fetal distress. Now, can I share my screen, please?
Yes, sir. Yes, sir.
Yeah.
Please share your screen.
Yeah. So good evening once again, and thank you for giving me this opportunity, Dr. Meenu and Dr. Vijay and Dr. Gopinath sir, and of course my friend, the dear friend Ashok. This is a very interesting thing that Vijay and Meenu has chosen, that is the clinical equipoise. Now, this is one of the most important clinical problems which we come across, which has definitely can be labeled as a clinical equipoise, because equipoise, as Vijay simply said, that I don't know. It is true, very much true, and it is a genuine uncertainty in the expert medical community. So that is one of the factors which prompts us to deal with this late onset FGR. Now I have a wonderful panelist,
They're brilliant and they are really, really good in this growth assessments. For Dr. Bimal Sahani, whom we know, and he is my dear friend, and he is the president-elect of SFM, and he is an ultimate word as far as management of fetal growth restriction is concerned. And then we have Vijay Balakrishna, who everyone knows about him, and he has a crystal clear concepts and a very good teacher. And the most important thing, of late, we have heard him talking about does size matter, which were wonderful lectures, 2 parts. And then we have Srilekha Warrior, who is a senior consultant and the head of the department of Lakshmi Hospital at Kochi. So with this panel, I think I'll just briefly take you through what late onset IUGR is going to be. The most important thing is that the impact factor which the fetal growth creates associated with short-term and long-term perinatal outcome, long-term abnormalities or long-term morbidities like neurodevelopmental abnormalities, cardiovascular dysfunction, as well as the metabolic syndromes. Now, before we go into the growth restriction, we need to understand what normal growth is. And for that, there are certain factors which are responsible for a normal growth of the fetus, such as the genetic factor, maternal, fetal, placental, as well as the external, that is the environment of the fetus. Now, for a normal fetal growth, what it requires is good nutrition as well as oxygenation. And placental function is one of the most important things to provide good nutrition as well as the oxygenation to the fetus. And any placental dysfunction is the one which results in growth restriction. If it is initially, it is the nutrition, then the oxygenation. So early onset and late onset FGRs are responsible for it. With this graph, we can very clearly understand that after 30th week, we can clearly see that the nutrition as well as the oxygenation is exponentially increased. The demands of the fetus will be increasing. And at that time, if the placental dysfunction is there, it results in growth restriction. Now, the approach is first and foremost thing to identify the small fetus, which is less than the expected fetal weight being less than 10 centile, and then differentiating it between the constitutionally small as well as the late onset FGRs, which are various factors which will dictate us to identify them as small for gestation. But the surveillance, there are 3 components as far as the growth restriction is concerned. 1 is the diagnosis, 2 is the monitoring or surveillance, 3 is the time and mode of delivery which we are going to aim at. So these are the 3 things that have to be kept in mind. So based on these factors, which we can differentiate FGR as far as SGA, which we will come across as we are taking through the panel. And these are all the various factors which we have to consider as well as the early onset and late onset. The arbitrary cutoff is 32 weeks and more. Whenever it is more than 32, we call it as late onset. The major problem is with the diagnosis. So the problem 1 is diagnosis. Problem 2 is the poor outcome. Problem 3 is the long-term outcomes. Now, basically, the placental disease, it starts off with and then there will be a compensated hypoxia, then there will be a decompensated hypoxia. And as this is a mature fetus, the tolerance to hypoxia will be very, very minimal. It can result in injury as well as the fetal death. So basically, because the placental injury in late onset is only 30%, less than 30%, initially there will be an incremental raise in the PI of the umbilical artery. Later on, there will be centralization with the middle cerebral artery being abnormal. Growth will be restricted. In that situation, we need to depend on CTG as well as the BPP. And we have to take, so basically we need to understand that the detection rate is only less than 50%. More than 40% of them result in IUDs, neurological, cardiovascular, and metabolic impact. So the differentiation is basically important between these. These are the prognostic criteria. 1 is the uterine artery Doppler, which is PI being more than 95th centile, CPR being less than 5th centile, expected fetal weight or abdominal circumference less than 3rd centile. And these factors are considered, and based on that, you can categorize them depending on the perinatal outcome as well as the long-term outcome. And the management basically has to be, that will be dealt by the panelists, which we are going to go through. And the clinical conclusion is, basically we need to understand SGA plus expected fetal weight, which is less than 3rd centile, abnormal CPR, uterine artery Doppler, and the umbilical vein, that is late onset FGR. Now, remember to consider expected fetal weight, anything less than 10 centile also to be abnormal, and be suspicious about a possibility of a fetal growth restriction, because we know that the stillbirths are quite often seen in the SGAs as well as the AGAs. Now, late onset FGR has degrees. So not always poor outcome. So with this, I will take you through the panel, and I invite Dr. Bimal Sahani to tell us about how do you define late onset FGR? At what gestation do you label growth restriction as late onset growth restriction? How common is late onset FGR when compared to preterm FGR? Bimal.
The definition of fetal growth restriction is the fetus which fails to achieve its genetically determined growth potential due to a pathological cause. Now, that is FGR, and an FGR which is diagnosed or which manifests after 32 weeks of gestation is what we label as late onset FGR. And late onset FGR is the one which is actually the one which is more common. It is seen in about 70% and 30% is the early onset FGR. So that late onset FGR is the one which is more common. So we can just take a cutoff of 32. There have been studies talking about 32 to 34, but okay, the Delphi consensus has agreed that okay, we take 32 weeks as a cutoff. So an FGR which is diagnosed after 32 weeks is late onset FGR.
Thank you, Vimal. Now I would go to Srilata Warrior. Ma'am, which is easy to diagnose? Is it the late onset FGR or the early onset FGR? And if it's so, why is it so? Srilata, ma'am, you have to unmute your.
I hope I am audible.
Yes, you are audible.
Am I audible? Yeah, definitely. It is an early onset fetal growth retardation which can be picked up easily by the radiologist or whoever does the scan, basically because the fetal biometry is smaller, the baby is smaller, but even though the diagnosis is easy, the management becomes difficult. The baby is small and they're actually preterm. But as the baby moves to beyond 32 weeks, in late onset FGR, the fetal parameters are bigger, so the diagnosis is generally generally missed. Only about 50% cases are diagnosed because there is a very high chance of observer bias, and we can miss a good number of late onset fetal growth retardation. But the good thing is that the management becomes easy because the baby has moved on from around 32 weeks, and so the diagnosis is sometimes missed, but the management is easy. But in early onset FGR, even though we diagnose better, the management becomes difficult basically because of the baby's small size and also the prematurity. Another added factor for the early onset FGR is that Doppler abnormalities, especially the umbilical artery abnormalities, become set in much more early, and it is picked up in many number of cases. Whereas in late onset, we cannot rely on the umbilical artery abnormalities, which are most often done along with most routine scans, but it is a cerebral blood flow which is affected and which may not be picked up, and so again diagnosis can sometimes be missed in late onset FGR. So the diagnosis is easier in early onset, but management is difficult in early FGR. The diagnosis is sometimes missed in late FGR, but management becomes easy. It is all because of the Doppler abnormalities which are picked up earlier in early onset FGR.
Yeah. Okay. Thank you. And can I go back to Bimal and ask him, is early screening useful in predicting late onset FGR? And if so, how do we go about it?
Sir, honestly speaking, early screening for late onset FGR has very, very limited value. If you go by only uterine artery Doppler, then probably would pick up only about 25% detection rate with a false positive rate of 10%. But if you add in other maternal characteristics, if you add in the mean arterial pressure, if you add in second trimester biometry, uterine artery Doppler, and even maybe PLGF and PAPE, still the detection rate would go to about 50% with a false positive rate of 10%. So yes, not great predictor. So early screening would have limited value. That is all I would say about that, sir. Hello. I think Praveen sir.
Yeah, his connection is not stable.
Okay. In the meantime, Vijay, would you like to add anything on early screening for late FGR?
The basic issue here is that when we are talking about screening, our endpoints have to be very clear. And the main reason why both for early and late FGR, you would find that screening does not work because our definition of growth restriction is wrong, which is we're talking about only babies less than the 10th centile. So that's the reason why when we're trying to screen and pick up something whose definition itself is wrong, we are going to fail. And in any type of study that we're going to know, we should know the endpoints very clearly. And if our endpoint is not clear, our our screening is not going to be effective. And the reason why the same modality works for preeclampsia is because of our definition for preeclampsia is very clear. We know what preeclampsia is, we know how to define it very clearly. But if you look at growth restriction, how do you define it? Less than 10 centile at 32 weeks or less than 10 centile at 36 weeks? Because you know that some of these babies drop to less than the 10 centile at 36 weeks rather than at 32 weeks. So the degree of placental damage is not going to be the same. So if we redefine growth restriction and find out, those babies that are going to have an abnormal MCA or an abnormal CPR or an abnormal uterine artery, irrespective of their size, then probably our screening modalities will be a little more effective. I mean, I'm just thinking out loud here. That's for research, basically.
So it's rather than the screening, it is using the right parameters for detection, which becomes more important.
Because right now, as a screening tool, it's difficult.
It's not very.
I think you've got Praveen Sir back.
Yeah.
While he gets his screen loaded, there are two related questions in the chat box.
Oh, yes.
And if I can put them to the panel, one is that in AGA fetuses, how do we diagnose insufficiency of the placenta? And if the estimated fetal weight is more than the 10th centile, but the growth velocity is low with Doppler abnormalities, should we call it late onset placental insufficiency rather than FGR?
You want me to take? I'll take that or?
Yeah, Vijay, go ahead. Yeah.
So the idea is when you have a baby that is above the 10th centile, we are going to logically think that they are not having growth restriction. But that is where we have to change the way we think. Because when you find that there is a baby that is above the 10th centile and that is less than the 50th centile and is showing signs of cerebral compromise, where you have an abnormal CPR or an abnormal MCA, or there is a drop in your growth velocity, those are the babies that we need to be worried about. And if you looked at Parvati's case, you would find that at 32 weeks, that baby was at the 33rd centile. So if you went by your original definition of growth restriction, you would probably have missed the bus entirely there. So instead of using AGA, I would suggest that if you find any baby that is less than the 50th centile, it would make more sense to look at the Doppler and see how this baby is basically. Is there compensation or not? And then if there is compensation and also if there is a suspicious drop in the growth velocity, I would suggest that you should put that baby on closer surveillance, because those are the babies that you're going to miss, and those are the babies that are going to land up in stillbirth and poor outcomes.
So rather than putting it across as we're looking for the small baby, we are ideally supposed to pick up those babies which are likely to have an abnormal outcome. Correct. Now, whether they may be between the 10th and the 50th centile, they may be less than the 10th centile, but may not have an abnormal outcome. So the primary focus is which are the ones which are likely to have an abnormal outcome.
Essentially, the focus is on trying to find out babies that do not reach their growth potential, which is hypothetical, but at the same time is possible because of Doppler that we have right now. And we can try to find out those babies that are having a problem in spite of being above the 10th centile.
So that's what, basically we are worried more about the hemodynamics rather than the size of the baby. Shall we go? I don't know where I missed the connection and then.
No, sir. We were discussing some questions from the chat box.
I know, I understand. So where are we now?
Sir, I just finished with
slides exactly where you left off. Yes.
Okay. I think Vijay has spoken about the histopathology of the late onset implications of this thing.
No, I haven't.
No, he hasn't.
I'll take this question on the histopathology of late onset and its implications. The basic idea in late onset, because this is or any pathological problem which leads to growth restriction, is that It's very unclear as to what exactly is the cause, but there could be a combination of infarction, hemorrhage, fibrosis, and all those things. But what is more important is the degree of placental damage. The greater the degree of placental damage, greater is the chance that the baby is going to growth restrict early. And when the degree of damage is lesser, the baby is not going to growth restrict earlier on, and it's going to show signs of smallness at later gestations. And the same thing happens with the umbilical artery. The umbilical artery is looking at the placenta, and therefore, if the placenta is severely damaged or is greater than the damage of greater than 30%, that is when you're going to get an umbilical artery abnormality. And that's the main reason why in late onset growth restriction, where the placental damage is less than 30%, the umbilical artery is going to be normal. It's just basically to understand that there is more demand than supply. So if 70% of the placenta is normal, it will be able to sustain the fetus till around 32 to 34 weeks. And after that, the baby's demands increase and the placenta is not able to match up with those demands, and you're going to get growth restriction. That's basically what late onset is. And that's why the umbilical artery is always normal in that subset. Yeah.
That is the basically the 30-70 concept,
Yes.
Wherein the amount of placental dysfunction is going to be.
Yes.
Okay, then can we go back to Srilata Warrior, where what is the role of umbilical artery Doppler in differentiating late smallness of gestational age FGR, and why is it normal? I think
I think Dr. Bijoy just mentioned about the same points right now, because it all depends on the percentage of the villus damage. Whenever there's more than about 30 to 40% damage to the placental villi, the blood supply to the umbilical artery, which directly is shown from the placenta, is affected more, and hence the umbilical artery waveforms become abnormal in early onset IUGR, where there is extensive placental damage in the early stage, and that causes early fetal abnormal biometry as well as abnormal umbilical artery. So the role of umbilical artery Doppler is basically because of more placental damage. The villus damage is more extensive than which occurs in late onset. In late onset, there is less than 30% placental damage, and so the umbilical artery waveforms are affected neither not affected at all or affected only late.
Right. Thank you very much. Now, can I go back to Bimal and ask whether the routine third trimester. Now, Parvati has shown us very clearly that the late third trimester routine scan are definitely going to be useful. So I would like to put it forward to you, Bimal. Would you like to do a late third trimester more than 32 weeks scan? And is it useful to identify the SGA fetuses? And what is the additional information we are going to get by using this particular third trimester scan?
Sir, primarily I'm little against the use of the word routine scan at 32 weeks, because people have misunderstood the word routine. Routine means they feel you just have to keep the probe and look at whether the liquor is normal and just overall look at it. So a 32-week scan has its own purpose, and we need to look at the biometry. We're going to look at the growth. We are going to look with how is been the trajectory of growth if we have earlier scans, and at the same time we need to look at the Doppler. So if you're doing a scan at 32 weeks, when you're looking for growth, it's important that we also look at the Doppler. So Doppler, according to me, should be an integral part of that. And definitely, it's not just 32 and 36 weeks. If we can add these two scans to the protocol, I think we would go a long way in detecting late onset FGRs. And of course, even birth rate, you have an EFW less than third centile, you have a straightforward, you have made a diagnosis of an FGR. And if you have anything, less than 10 centile, you have an SG, you have an SGA. And as like Bijoy said, between 10 to 50th centile also with an abnormal Doppler finding. Even though if you don't, you're not able to say at that moment that this is an FGR, you will be able to put these fetuses into more regular surveillance, because it may be an AGA at 32 weeks, it may become an SGA at 36 weeks.
Yeah, so that's why it almost triples the detection rates. Going to do these serial scans. Okay. Then Dr. Srilata Warrior, once a small fetus is diagnosed, next step is to differentiate differentiate FGR and a constitutional small? How do we go about it?
Yeah, the basic idea is that we diagnose a baby who is having a less than 10th centile. We diagnose it as a small for gestational age baby. Once a small for age baby is diagnosed, the main idea is to differentiate between a pathologically small baby and a constitutionally small baby. So the most important thing is that if the estimated fetal weight or the AC comes to less than 3rd centile, then definitely there is a pathological growth retardation. Because a constitutionally small baby can be somewhere between the 3rd centile and the 10th centile, but it never goes below the 3rd centile. So below the 3rd centile is definitely pathological, and we have to treat it as a growth retarded baby. And all babies who have less than 10 centile, of course, we have to look for Doppler in every baby, but especially need a regular follow-up for Doppler for all who are less than 10th percentile in estimated fetal weight and AC. And those with an abnormal Doppler, definitely we have to treat them as fetal growth retardation. So the simple equation is that any small for date baby, if there is an abnormal Doppler, it is a pathological growth retardation. Any small for date baby which is less than 3rd centile is also a pathologically growth retarded baby. Right. And these are the babies which need a regular surveillance depending on how much of the Doppler or the growth retardation has happened.
Right. Bimal, do you think that growth velocity will help us in predicting adverse perinatal outcome?
Yes, sir. In sense, because when we're talking about growth velocity, what we practically are looking for is the trajectory. You know, how's the growth? You know, we are plotting longitudinal. We are looking at the longitudinal growth curves, and yes, if you have dipping in the growth curve, or you have a fetus going from higher centiles to lower centiles, so you have deviation from the normal trajectory, then you know, they have been associated with adverse abnormal outcomes. But you know, more so when we have Doppler abnormalities, they are more likely to be associated with adverse abnormal outcomes.
Yeah. So basically, the limiting factor is that the declining expected fetal weight as well as the AC lack interval time frame, that there is no specific interval time frame that has been quoted to say that this is when you can call it as, except that there is a less than 30th centile is one thing, and quartiles are more than 3 quartiles is what is very
important.
Quartiles,
yeah. So that goes to about 50% dip in the velocity.
Yeah. Now, Bijoy, can you enumerate the Doppler parameters? Because we are talking a lot more about not only the biometry, but also we know that Doppler plays an extremely important role as far as the late onset FGR is concerned. We would like to know about the various parameters which you would like to evaluate, as well as tell us how to evaluate and what are the points to look for.
As far as Doppler is concerned, the most important one would be the brain Dopplers, because these are the ones that will tell you that there is hypoxia or not. So when you find that the baby is small, you look at the baby's brain, look at the middle cerebral artery, and try to find out if there are signs of hypoxia. Now, having said that, MCA is not a good surveillance tool. The biggest mistake that we do is we look at the MCA and we try to see if the MCA is falling less than the 5th centile before we say it is abnormal. But the problem with MCA is that it drops very late, at least greater than 36 weeks. And therefore, the most important Doppler that you should be looking at is the CPR. Because the CPR starts its drop from 32 weeks onwards and then progressively drops further down. And therefore, CPR is the Doppler that you should be looking at, and that should be what your surveillance is based on. So that's about brain Doppler. The other Doppler that I would be interested is the uterine artery, because the uterine artery tells you whether perfusion, maternal perfusion, is good or not. So if you find that the baby is small, and if you find that the uterine artery Doppler PI is high, it tells you that the maternal perfusion is less, and therefore you have a pathological cause of smallness. Now, apart from that, an important point is that if you find that the uterine artery is abnormal, there is a 2 to 3-fold chance that there would be abnormal brain Dopplers towards term. So it gives you two things. One, it gives you the diagnosis of late onset growth restriction when you find that the baby is small. And the second thing it tells you is that this baby is going to have hypoxia at term. So it tells you that at term there is going to be hypoxia, and therefore these are the babies that could land up in severe problems if you try to induce them, or if you try to go in for delivery at 40 weeks. So you have to pick them up out. The other Dopplers I would suggest against using, and the first one is the aortic isthmus. I would not suggest the use of aortic isthmus in late onset growth restriction at all, because the aortic isthmus is a watershed area. It contains four important parameters: the right ventricular output, the left ventricular output, the peripheral resistance within the placenta, and the peripheral resistance within the brain. So when you find an abnormality within the aortic isthmus, whether it is reversal or complete reversal or net reversal, it is very difficult for us to say what actually is the problem. Is it because of compensation within the brain, or whether it is a problem because of right ventricular output or of the left ventricular output? It's very difficult to tease out the abnormalities here. And it is very unlikely to get an aortic isthmus Doppler that is bad with net reversal in late onset growth restriction, because the umbilical artery is still normal and therefore the afterload of the heart is not affected. Another Doppler that will not be of any use is the ductus venosus, because there is no cardiovascular adaptation in late onset growth restriction. This heart is beating perfectly. There is no strain on the heart. The heart does not have increased afterload. It is not overworked. It is suffering from mild hypoxia, but that hypoxia is not enough to cause cardiac failure. It is the brainstem that is going to get suppressed, and that is going to in turn switch off your heart. So here, the ductus venosus has got absolutely no role. So if you sit on late onset growth restriction, waiting for the DV to reverse, you're going to miss the bus completely, and that baby is going to die. So the point here is, remember CPR and uterine artery. Those are the two things that you need to look at in late onset growth restriction.
So the bottom line is that you need to work on the the CPR, and then the middle cerebral artery, and CPR by getting the umbilical artery PI as well as the MCI PI. Thank you, Vijay. Now, Vimal, can you tell the role of Doppler parameters in late onset? How do they implicate composite adverse perinatal outcome?
Sir, actually, Vijay has nearly taken us through these things, but he talked about the uterine artery. That is very true. An abnormal uterine artery in late onset, of course, it not only tells us that there is a chance of hemodynamic redistribution taking place towards the end, but that also has been associated with increased cesarean sections and postpartum problems. Then it is there are studies which have shown that an abnormal CPR definitely has an association with hypoxia and immediate postnatal adverse outcomes. So two things: umbilical artery, because in most of the cases is going to be normal. But again, Vijay has already taken this point where, that when we say normal, because even if it is at the 90th centile, we will call it as normal. But it is already telling us, and that is why the CPR becomes more important, because it is taking both the MCA and an MCA at 10th centile is normal, an umbilical artery at 90th centile is normal, both are normal, but at that time the CPR is going to be less than the 5th centile, and that actually is going to be more predictive of an adverse outcome in late onset FGR.
Yeah, that was very well brought out by Parvati in her case, where she has very clearly shown that the MCA and the CPR was the one which was the triggering factor. And another important thing I want to ask you as well as Vijay is that suppose we have a uterine artery which was absolutely normal in the first trimester and suddenly becomes abnormal in the second trimester, does it trigger off anything?
If it becomes abnormal, there is still, and if the baby is small, if the baby is not small, I'm not very worried about it. But if the baby is small and you have already done your screening with uterine artery in the second trimester, and then you're looking at it again, it can become abnormal. It is possible to get a late onset issue there, because there are a number of reasons for it. It could be inflammation. It's still not known, but it is known to happen. You can have a completely normal uterine artery in the first trimester and in your second trimester, and then find out that it becomes abnormal and it's seen especially in late onset growth restriction cases.
But if there is an AGA with an abnormal uterine artery, I would still put them on, a follow-up, put them on surveillance.
Naturally.
Yeah, because we're looking
the whole idea is not about just picking up on one sitting. We just need to pick up all these small things which tell us that, yes, this is a baby which is likely to have problems. So this is the one that we are going to, follow them up more frequently as compared to others.
Yeah, actually, that's the reason why I think he has called it as equipoise, because there are so much of uncertainty that you need to add every small small point to your armamentarium in order?
Actually, there is no equipoise here because we are all speaking the same language. So I'll just tell you what the other party will be saying. There is an equipoise to this. There is clinical controversy. And the controversy here is that one, if you do unnecessary Dopplers, you could land up in unnecessary intervention. And that has been the major argument from all bodies of fetal medicine, including the people who came out with the diagnosis of late onset growth restriction, who have talked about not using Dopplers in AGA fetuses because you would increase the risk of unnecessary intervention. Now, the other group, the group that we are, who say that we should use Doppler, because the unnecessary intervention that would be involved here is basically induction at term. And induction at term is basically at 38 to 39 weeks, and that does not change the perinatal outcomes in any way. And that is the reason why that's the reason why for the AGA babies, looking at Dopplers and picking up on those fetuses that have probable signs of brain redistribution would be useful. Because if you don't do that, we would miss out on at least 40 to 60% of stillbirths that happen, and those happen in babies that are above the 10th centile. So if you want to make a difference in the stillbirth rate, you have to run the risk of slightly erring on the side of caution. And yes, when you do that, there is this issue of unnecessary intervention. But if you decide to beforehand that your triggers are very clear, in late onset growth restriction, your triggers should be very clear. Your triggers are not abnormal CPR, not abnormal MCA, not abnormal uterine artery. Your triggers are the biophysical profile. And if you know your triggers very well, it is very unlikely that you will end up in unnecessary intervention. Yeah.
And I would point to, because I belong to the same group which supports the use of Doppler, even in AGA, is because we need to look at our circumstances. In the kind of practice that we have, where we are not sure about the dating scan. The scans are done at different places, dating at someone else's place, the second trimester. So all this talk about looking at the velocity and looking at the growth trajectory and then taking a call whether it is dipping down from the before. This would all depend if, if you're doing all the scans or there is a standardized method which is being followed there. So, and with the controversy regarding with growth chart to follow, all these things put together, I also believe in this thing that we need to take Doppler as this thing. And of course, we're not saying that on one reading, we need to just get the baby out, but yes, that definitely helps us in putting them into higher surveillance.
Surveillance. Yeah, thank you very much, both of you. And now we will go back to Srilata Warrior. And how do we improve the risk profiling in late onset FGR? In which way is this information going to be useful in managing these fetuses?
Yeah, so like in late onset FGR, again, it is important to differentiate between just a constitutionally small baby and a baby with a less than 10 percentile baby with a pathological growth restriction. As we discussed before, any baby who has got a severe smallness, that is, has got an estimated fetal weight less than 3rd centile, or any small-footed baby with an abnormal CPR, definitely the perinatal mortality becomes high. So I will be very skeptical when I look forward into the timing of delivery and also the mode of delivery in such a patient. For example, as Dr. Parvati has told about this particular patient, an ICSI pregnancy, having a baby less than 3rd percentile and with an abnormal CPR, I wouldn't say that I would never even plan for an induction for such a patient unless things are very, very favorable. I would go directly for a cesarean section. So the baby weight, if it is less than 3rd centile and a less than 5th centile of CPR, I would be very careful in planning my strategy. And if at all I'm planning for a vaginal delivery, it will be taken upon with a lot of caution, with a continuous fetal heart monitoring and with an adequate counseling that there's a high risk for a cesarean delivery, including meconium and NICU admission. So that will be decided after discussing with the patient, and I would be very careful. The risk profile basically depends on the centile. If it is less than 3rd centile and abnormal Doppler, again, we have to be very cautious in delivering those babies. I would suggest that we induce them earlier, if at all, at around 38 weeks, and we wouldn't go beyond 38 weeks. Actually, in our center, we are very skeptical about and we're paranoid about these small-footed babies. So we pick up a lot of them, and we don't go beyond 38 weeks in any small baby, especially if the Bishop score is good. And if they are really small, the pathologically small ones, we don't go beyond 37. And the decision is generally taken along with the help of the biophysical profile and also the NST.
Thank you.
This all adds on to decision making.
Yeah, I know. I mean, that is the most important sensitive thing that we need to do about. And can I go back to Bijoy and ask him how to plan an antenatal surveillance in this later? Because that is one of the most important components. As we have defined, definition of FGR, diagnosis of FGR, surveillance, and then the management. So the second part of it, which is extremely important, can you enumerate or explain to us how you are going to take us through the surveillance of these late onset FGRs?
This be very brief because we are actually running short of time. So I'll just be very brief here. The basic idea is when you are doing surveillance in late onset growth restriction, we have to remember that we are looking at the brain stem, because here there is no cardiovascular adaptation and we are looking at signs of hypoxia within the brain stem. We are going to use CPR to understand how frequently we have to do our surveillance. Normally in late onset growth restriction, they say that you have to do surveillance once a week. But if you find that your CPR is dropping, then you would increase your surveillance. And in your surveillance, you're going to add two things. One is the CTG, which is going to directly look at the brainstem, and other is the breathing movement of the fetus, which is the first center in the brainstem that is going to be suppressed with hypoxia. We are not worried about the amniotic fluid. We are not worried about anything else except these parameters. The CTG, if it is reactive, if the baby is breathing, we continue to monitor, we continue to do our surveillance. We increase the surveillance if we find a dropping trend in the CPR. That's in a nutshell.
Yeah, then what are the neonatal and infant consequences associated with late preterm FGR?
The outcomes are excellent if we make the diagnosis and if we time our delivery. If we miss the bus, if you don't make the diagnosis and if you go in for induction at 40 weeks, and then you have all these problems of fetal distress, neonatal acidosis, and all those things. Otherwise, the outcomes are excellent because that is the group where there is only mild hypoxia, mild to moderate hypoxia, and the heart is good. There is no cardiovascular adaptation. These babies do extremely well, and they do poorly only most of the times when you miss the bus and you push them towards 40 weeks and they are in a continued state of hypoxia. And most of the studies on late onset growth restriction are based on postnatal studies which have looked at babies that have been completely missed. You have completely missed and you find that the baby is born growth restricted and then they show long-term poor outcomes. But otherwise, if you make your diagnosis at the right time, if you find your exact trigger, these babies are going to do extremely well.
Yeah, thank you. So, Vimal, what are the long-term consequences which you expect in these late SGA fetuses?
Yeah, in continuation with what Bijoy has said, if not brought out at the right time, then yes, these babies can have poor performance in school, and there is a high incidence of metabolic syndromes and increased risk for adult onset diabetes mellitus. Yes, these are the long-term consequences.
Yeah. Dr. Srilekha, Srilekha Warrior, what are the factors considered in composite adverse perinatal outcome? Though we will not be really following these things in our practice, and just for the completion's sake.
Yeah, so for the composite adverse perinatal outcome, we look into 4 factors, and those are the 5-minute SUBGAR if it is less than 7, the umbilical artery pH again which is less than 7, a requirement for neonatal intensive care admission, and also the need for an emergency cesarean for fetal distress. These 4 factors are taken into consideration for the long-term, it's basically a research modality which we are not usually used in our general clinical practice.
That's right. Bijoy, now as we have almost understood very clearly about the diagnosis as well as the surveillance, what would you, what are the recommendations that have been postulated in managing HGRs?
Yes, sir. Yeah, so the ZOA guidelines is basically the same. Can you hear me, sir? Hello? So the ZOA
yes.
It's the same thing. So we look at the mother and the baby, and in this group, in late onset growth restriction, preeclampsia is not that common, but it's still possible. So you look at the mother, if there are no maternal indications, we take them to term. And we look at the brainstem and the CPR, as I told you. If the CPR is falling, we increase surveillance. And if you find that there is an issue with the brainstem, that is, if you find an abnormal biophysical profile, or if you find an abnormal CTG, since we don't have computerized CTG, I'm not going to talk about that. We still rely on our normal CTG, and that itself is good because you can pick up lack of variability and late onset,
It is
unprovoked.
obvious in your case.
So all those things can be seen. So your triggers for delivery are going to be an abnormal biophysical profile or an abnormal CTG. And if everything is normal, we take these babies till 38 weeks. Now, if you find that the umbilical artery is becoming abnormal in between, then you reclassify them and then take them a little bit more earlier. But otherwise, usually your delivery is after 38 weeks. And the best part about late onset growth restriction is if you make the diagnosis and if you decide not to do anything, I'm not going to do surveillance. I don't have a CTG machine. I don't have Doppler. I don't have anything. I just made the diagnosis. And if I deliver all of them at 38 plus weeks, I will reduce the mortality by 50%, just like that. And so if you do your surveillance, that mortality rate is going to fall even further. And that's the importance of late onset growth restriction, that is making the diagnosis.
Very nice.
Management, as has already been said, is just to go and deliver at 38 weeks, unless these triggers are present. Normal biophysical profile, abnormal CTG.
Thank you. Thank you. Now, Bimal, what about the
Yes,
Barcelona?
sir. I'm so sorry, but can we quickly wind up the panel? We are actually quite much.
I think, okay, I'll go back to the last thing. Anyway, thank you.
Yeah.
Thank you very much. And the clinical conclusion is that we have come to an understanding that ACA plus expected fetal weight less than, this is just to summarize. And most important thing is that consider or expected fetal weights which are more than 10 centimeter also as abnormal, and be more cautious about it. Thank you very much.
Thank you all. Thank you, Dr. Praveen.
Thank you, sir. Thank you very much.
Thank you. There are quite a few questions in the chat box, but unfortunately, we don't have time to do that. So I think we will try to answer these questions.
Yeah.
We will try to answer in the chat box itself.
Yes, and I would like to go to the next clinical equipoise, that is the intermediate risk. And I would like to invite Dr. Vidya Lakshmi, who is the head of the department of KIMS Trivandrum, to go through her case, and then Khurana sir will be dealing with the equipoise, and I'm sure in his own inimitable style.
Good evening, all. I'm seeing about 500 participants. And Khurana sir, shall I start?
Yes, please go right ahead.
Okay. The topic which is given to me is combined risk, and then how to take care of an intermediate risk. So this is a lady who is presented to us. She's 35-year-old. If you want to call her as advanced maternal age, I'm not quite sure. She's borderline 35 years. The last childbirth was about 5 years back. Second gravida, first was a spontaneous conception, uncomplicated pregnancy and delivery. Delivered a female baby of 3.2 kg at term at 5 years back. This pregnancy and the last pregnancy was uneventful, and she's now with us for the first trimester screening at 12 weeks plus 3 days. The scan was performed. You can see that the nuchal translucency is well within normal range. If you want to call us, it is 0.9 multiples of median. Nasal bone was ossified, and the tricuspid regurgitation was absent, and the ductus venosus showed a normal forward flow. So, because she's 35, she had a first trimester scan done, which was looking good. She was offered the first trimester combined screening, which is a usual protocol which we also follow in our center, because 35 years we don't directly take them to NIPT unless there is any other concerns in the scan. So she was discussed with the options of first trimester combined screening versus NIPS. The family opted for first trimester combined screening, and we did the first trimester PAPE free beta SCG, and this is how the report has come. If you can see here, her age-related risk, what is the a priori risk, is 1 in 368. But post-test risk, that is after the screening where we did the hormones, the risk has now come back to 1 in 310, which is almost close to her a priori risk, which is not really much modified after the post-test. And a little bit about the hormones. If you see the pre-beta HCG, it is around 1 mom. The PAPE is slightly lower, which is 0.23 moms, which may be the culprit for the intermediate risk scenario. So the patient comes back with the report to us after about a week later. So there is already a pre-test counseling which has happened, because all the patients who undergo the first trimester screening, irrespective of their age status, we talk to them about why the screening is done, how is it performed, what is expected of the screening, and post-test counseling will follow once she gets a report. So the report showed an intermediate risk. So she was again counseled regarding the implications of the intermediate risk concept. And also the family was worried why the PAPE was low. What is the implication of having a low PAPE? So as we all know, in spite of having a low PAPE, it can just not just aneuploidy. So the other causes or the other associations of low PAPE were also explained to her, like onset of preeclampsia, gestational diabetes, growth restriction, preterm delivery, and so on and so forth. And at this point, the family wanted to know a little more about NIPS, because they wanted to think about the other options also in a little bit detail. So we discussed with them that you are in the intermediate risk group. It's not high risk. It is still more than 1 in 250. The scan was absolutely looking good, because none of the markers were positive in the first trimester scan. With the nuchal translucency, was looking less than the 99 centile. All the markers were negative. So we counseled regarding NIPS, the pros and cons. If the family is opting for NIPS, the right time would be to do it straight away, so that she gets some time to think about and act upon the reports of NIPS. So after the counseling, the family decided that no, we don't want to go with NIPS straight away. We would wait till 18 weeks and then come back and see how it goes. So she comes back for an 18-week targeted scan, and this is what we saw. There was an echogenic cardiac focus in the left ventricle, which is almost always seen in a majority of the cases sometimes. And especially when you are in doubt for this, there's one marker which will always be there to add on to the confusion. And she also had a bilateral renal pelvis dilatation, UTD-A1. So again, everything was discussed, because we told you are 35, but you're very, the first trimester scan was fine, but your risk was 1 in 310, maybe because of PAPE. But now we are seeing 2 markers in the anomaly scan, may be significant, but not really. We are not able to tell you whether the chromosomal status is completely fine or not. So the family then again discussed, and they decided, no, we are at 18 weeks now. We don't want to take up NIPS now, because even if it comes back as normal, we are not going to be 100% happy. So why don't we go with amniocentesis? Then the counseling regarding an invasive test was also given. We told the very small risk of miscarriage, even though it is very small, 0.1% was told to the family, but they were okay to take the risk. So an amniocentesis was performed, and that is how the karyotype came back. It showed no evidence of aneuploidy, and this is a pure PCR. And then following that, the CMA also came, which was also negative. So very happy, and the pregnancy was followed up because it was UTD-A1. Definitely the urinary tract was to be followed up to see whether there is any ongoing dilatation. We didn't show any progress. ECF-LV or echogenic cardiac focus, we forget once the screening is done and the report of NIPS or the amniocentesis is normal, then it is not going to be getting worried on us. Structurally, everything was fine in the heart. The rest of the course of pregnancy was uneventful. She was very happy and then delivered at 39 weeks a male baby of 3.4 kg. This is all when it goes very well, Rosie, but this is not always the occurrence, because it's one of the very tricky situations when the couple comes back to you, especially when they're very learned. When you talk about intermediate risk, it's not always very easy. With this, I stop my case presentation, and I would like Ashwaparana sir to intervene. Hello, sir.
Thank you, Dr. Vidya Lakshmi. That was an excellent presentation. And for those of you who don't know her, she is a senior consultant coordinator of the Department of High Risk Pregnancy and Perinatology at KIMS Health in Trivandrum, and has a background of training in Sydney. Thank you for that excellent presentation. That has indeed gone off very well, and is going to form the basis of what is actually what we're going to be discussing over the next 20 minutes. I am trying to see if my screen decides to behave itself, and sometimes it does these naughty things, but let me see if I can get my screen share going. I seem to be picking up a Dropbox rather than my screen. let me just see how best I can handle this. And I will restart this in a minute. My other panelists tonight are Dr. Radhamani, and Dr. Radhamani has received the Best Professor Award for obstetrics and gynecology, and is also is retired from the Government Medical College and currently the head of the department at Amrita Institute of Medical Sciences. Then we have Dr. Sinish, who has, as you know, a master's in fetal medicine from Barcelona, and is a senior consultant at ARMC Aegis Hospital in Penintalmana. And I'm just trying to get my screen share going in a minute. And let me see how it works now. And I still don't see my screen as yet, but let me see if I go to my full screen, whether I can sort that out. Are you able to see any part of my screen so far?
Yes, sir.
You can?
You got it.
Sir.
Yeah.
Wonderful. Then I feel a lot more comfortable. I also have to introduce two more panelists, Dr. Meenu Batra, who, as you know, has been putting together, along with Bijoy, all these fantastic programs for the last so many years. She is a consultant radiologist at SIMAR Kochi. And our other panelist is Dr. Matthew Thomas, who is our joint secretary of the Kerala chapter of the Society of Kidney Medicine, and is currently in Kochi, where he runs his own center. Welcome all of you, and we will talk about something that is perhaps not as controversial as what we just saw a little while ago. We will talk about this intermediate risk and what we can do about it. So we'll take you very briefly through screening versus diagnosis, because we need that background. We also need to talk about risks and then cutoffs, which is the main topic. The methods of screening, just to give you a background, handling these results, and basically to emphasize how this whole story is about improving detection rates and reducing false positive rates. After all, that really is the exercise, way beyond the blood and the nuclear translucency scan. It's important to put the pieces of the jigsaw together and make sure that each one of us who actually handles the patient is on the same page and does not speak a different language. So here we go. We do know that screening is not merely a test, but has to actually be a whole process. And we must be able to make sure that the information is understandable by all, which is part of why we're having this exercise, so that we can have informed decision-making, timely access to the screening test, systematic notification of the results, referral for follow-up testing, and access to an intervention as well. Of course, we must make sure that our patients can decline the next step, and you saw exactly what the patient has done here. She decided that, well, let me wait until 18 weeks, let me see what comes on, and then I will decide. And then, of course, we make sure that new technology can come in at the right time. So using that as a starting point, Dr. Vidya-Lakshmi, thank you for that excellent presentation. We will briefly introduce this concept of markers, risks, and cutoffs. We know that markers are important only because they help us in calculations, but not really a marker in themselves. And when we put these, when we put clinical factors, ultrasound markers, and biochemical markers together, we get the assessment of risk. And the risk is then interpreted in the perspective of cutoffs that guide us towards or away from further testing. So that is what we're going to discuss over the next 15-20 minutes. And we know that if we don't do this whole process correctly, as you just heard, we will miss out. So we must include as much as possible in terms of the clinical features, make sure that our informatics is correct when we fill out forms, make sure that we do at least the nuclear translucency and add on the others depending on the situation, and then get the right answer along with biochemistry. So my first question here is for our presenter, Dr. Vidya-Lakshmi. What is the difference between a screening test and a diagnostic test?
In a broader perspective, as any screening test is offered to the general population. It's not to be offered to a specific risk group. So it is universal. It is to be offered to every woman, because the risk is not the age, as we previously thought. The risk is pregnancy. The risk is that she has a baby in the womb. So nobody escapes from the screening. So it should be universal. And second is it is used in a large cohort. It is not just to be specified to somebody who has got a family history, previous baby, no. It is to be offered to the large cohort. It's for that matter to everybody who is pregnant. Third is it should be simple, easily accessible, and you should have trained people to do it as easily it can be performed. But the sensitivity is very important when you talk about any screening test. It should have a very high sensitivity because so that you don't miss out in the general population. Because, for example, if we take only women above the age of 35 and screen them, we are really going to miss the majority of the chromosomally aneuploid babies because we are seeing only the tip of the iceberg when we screen only the advanced maternal age women. And it should be simpler, much acceptable to the women. It is cost effectiveness is very important. So these are all put in a screening test. What is the disadvantage? It never says yes or no. It only says whether there is something goes wrong. There's a risk assessment. Maybe you're high risk or low risk, but it never says is it present or not. Diagnostic test on the other side is almost going to say that the disease pathology is there or not, but it should be very highly. The sensitivity is more in a screening test, but the specificity is more in a diagnostic test. The difference here is it is usually an invasive test. What does that mean? It involves a needle most often, and if so, the risk is not zero. There's a very small risk of miscarriage, which may be 0.1 to 0.2%, even in the expert hands. So these are the basic differences which I would mention.
Yes, and thank you for that. And so taking on from there, we say, all right, so our basic concept is that biochemistry and ultrasound are screening tests, and it's the diagnostic tests that give us a specific diagnosis. And we always have to include the entire population, not just a selected population. Today, of course, we're discussing mainly trisomy 21 and the intermediate risk. And it's not so easy as it always seems, like the Hitler amongst the Mother Teresas, but more like the others, like the owl amongst the pussycats. And that the other thing we must realize is that there are three aspects. There, like you just said, there is the screening, there is the diagnosis, and there is the procedure. And for those of us who are new to fetal medicine, the procedures would be coronary villus sampling the first trimester and amniocentesis in the second trimester. Cardiocentesis really is hardly ever done now. And then we send it off to a lab to get the right answer in the right way. So my next question is for Dr. Sinish. Why do we need to screen? Why don't we just do a diagnostic test on everyone?
Thank you, Kuran sir, for the question. Now, I think this is a very basic question which most of the audience would be knowing. Now, as we all know, screening is basically a strategy to identify the unrecognized disease from apparently healthy individuals. Now, let us apply this to Down syndrome and see. Now, Down syndrome, though rare, seen in 1 in 700 women, has a typical thing that its ultrasound phenotype may be restricted. That is, only 40 to 50% cases may show some markers. Second thing, the impact that a condition unrecognized and diagnosed at birth has on the couple, has in the community is too much, whether it be the financial impact or the loss of quality of life. Thirdly, we have a test which costs just a couple of hundreds and which is able to detect this condition with a detection rate or sensitivity of greater than 90%. So when we consider all this, Down syndrome is one prenatal condition that warrants screening. Now, if we do a diagnostic test for all the women that come to your clinic, we would be greatly enhancing or increasing the financial burden. Now, then to get an exact picture of this in a private healthcare is difficult, but if you see the figures from the FMF UK, where they have brought the cost benefit analysis, performing a diagnostic test or even an expensive test such as NIPT costs billions of dollars. So when we have a screening test, which has a very good sensitivity, which we can improve by addition of several markers, for which we can take a cafeteria approach, yes, screening seems to be the best strategy for Down syndrome for your woman.
What about this fear of invasive procedures causing miscarriages?
In the beginning, maybe the figures were exaggerated, but we know from the meta-analysis which was done from FMF UK, I think from the by the Akolika group, that the excess miscarriage rate, now all pregnancies have a miscarriage rate that is around 1 to 2%. Now the addition of an invasive procedure to this, to The additional miscarriage rates due to a procedure is about 1 in 200, maybe say like 0.5 for an amnio and CVS. So that means it might not be acceptable for all women, even though marginal. And it again calls for performance of a screening test than diagnostic test for performing a condition which is phenotypically hidden in most of the cases.
Good. Thank you for setting the stage right for us. And our next question is for Dr. Matthew Thomas. What are the parameters for accuracy? Because that's what our patient wants to know. They're not bothered about the science that we use. What does accuracy mean in screening, for instance?
So to maintain, thank you, sir, for the question. To maintain the accuracy, so basically we need to know that screening is a process that needs to have specific protocols for each component. So our basic aim is to have the maximum detection rate with the lowest false positive rate. So to increase the accuracy, we have the first and foremost the accurate dating by ultrasound is the most important one, as the mom is actually titrated for that gestational age. Now, the time period for screening is actually between around 11 to 13 weeks, 13.6 weeks, and the CRL should be between 45 to 84 mm. And the CRL and NT measurements should be strictly based on the protocols and recommendations. And because inaccuracies in NT, it usually has a significant negative impact on the detection rate. So the CRL also, even with minimal errors, it can lead to like miscalculation, particularly those in the borderline risk. So for the sonographers actually should be trained, to adopt the given guidelines, and you should perform regular audits also. So so it's not only that, it's also important to take care about the blood collection, the sampling, and also even logistics. So the serum sample is about 3 ml. We take it, and we should make sure that the test is not done if an HCG is given like within a week. And it is always good to transport it immediately to to avoid raised HCG values at high temperatures, where in that case, actually dried blood spot is actually more stable in that case. And the requisition form should be actually filled in detail, such as the basic demographic features, information, the gestational age, the maternal weight, the family. We have to let them write about the family history of Downs, the race, whether there is any family history of whether also the NT, the CRL, also the markers also has to be mentioned in the form. And also the lab quality also should also meet the standards. Actually, the approved softwares should be the one which is approved software should be used actually. So with all these parameters maintained, we can increase the accuracy of the combined screening test.
Yeah, thanks. Dr. Meenu, the mathematics of this whole situation, this detection rate, this false positive rate, etc., that is what really pushes us to try the intermediate group. What is your remark on this?
Yeah, so the mathematics always becomes a little complicated for all of us to understand, and we always hate these terms of detection rates, false positive rate, and odds of being affected by a positive result. So I will put you, it's a very simple example. So detection rate basically talks about how many of the abnormal people with the disease that the test can pick up. So if you're talking about 100 patients with Down syndrome, and this test can pick up, say, 80 patients, it would say that the detection rate is around 80%. Whereas when you talk about the false positive rate, that is the amount of people who were unaffected but came with a positive screening test and underwent an amnio. Now, when you're talking about the false positive rate, you're basically going to talk about the whole population. So what we are doing is, if you have a population of say 1,000 people and you have 100 people who underwent this test unnecessarily, that would form your false positive rate. And to increase the accuracy, or to say that the test is best, what we try to achieve is a test with the maximum detection rate with the least amount of false positive rate. But the most important thing that comes is your OAPR. And that is what comes into role when you're actually counseling the patient. Because see, for example, if a patient has a risk of say 1 in 100, so we generally, when you're sitting in the OP, you end up telling the patient that, out of 100 people, 99 will not be affected, only 1 is going to be affected. But the patient wants to know, what is my risk? What is my chance? And that is where your OAPR will come into play, because that will correctly tell you. For example, if you look for combined test, your OAPR is say 1 in 22, which tells you that your risk is around 4%. So you can exactly be able to counsel the patient, telling that, your risk of having an abnormal result after being screened positive with a good combined test would be around 4%.
Yeah, thank you for that. So essentially, then we realize that if we want to increase our predictions and not make so many mistakes, we need to do something about it. And one way, of course, is to make sure that we choose the right thing, which means we do first trimester screening, and we never do an NT alone, and we never do biochemistry alone, and we do a nice standard combined test. So that would be then definitely a great detection rate of 85 to 95%, with a wonderfully acceptable 5% false positive rate. And if we were to combine that with additional ultrasound parameters, we go up to 96% with a marvelous 2.5% false positive rate, and the second trimester falls far behind. So this is where we're trying to get in and improve our detection rates. And the other way, of course, to do that is to add on the question of are we going to just stick to this? Are we going to move on to our first trimester quad or our first trimester penta and so on? But I want to go beyond that and move straight to our, now that we have enough background, to our actual topic, which is the question on what are cutoffs. And when we've done this background of screening and risk calculation, Dr. Adamani, what exactly are cutoffs and do we really need them?
Cutoff is an arbitrary value that ensure that too many Down syndrome cases should not be missed. That also to ensure that we should not do too many invasive procedures. Actually, the cutoff for different countries use different cutoff values. And India, the cutoff value is about 1:250. And for the intermediate risk, we consider it's 1:1000. And these cutoff values are needed. Actually, we measure the cutoff values. Then when we get the value, we will see whether the values, the result is which is above or below the cutoff value. So this is needed because we are now able to categorize the patient into whether they are high risk, whether they are intermediate risk or low risk. So that if there is a low risk, no further interventions are needed. Whereas high risk, the diagnostic testing like CVS or amnioreduction depending upon the gestational age, and intermediate risk actually, intermediate risk then we can plan offer the contingent screening that is either a ultrasound soft markers or the second trimester screening or the cell-free DNA or genetic ultrasound. This is the advantages of cutoff is needed to know whether there is the said pregnant patient is a high risk candidate or a low risk candidate or intermediate risk candidate. And actually, this risk again recently in other US outside states and outside abroad, it is a 1:10, 1:51,000, and but in India it is 1:250 is considered as the cutoff value.
Yes,
more about I can sir can add it.
Yeah, we'll come back to that in a few minutes on what should be right for us and the definitions. Dr. Sanish, we come across charts like this all the time, and I dislike them. And I always call people like you to help me out with them. And what if we use this cutoff? What will I miss out? What if I do this cutoff? What will happen? How do I handle all of this? What's the background?
Basically, and especially for the young fetal medicine fraternity of our country, the screening for any prenatal condition is based on Bayes' theorem, which was introduced by the Fetal Medicine Foundation. So in this Bayes model, we know that the sensitivity and specificity are actually a kind of inversely proportional to each other. And you have a two-way graph, which is called as a receiver operating characteristics. Now to simplify, when you use a smaller cutoff, the sensitivity will fall, but the false positive rates will also fall. That means the test will be more specific but less sensitive. So look here. In the first row, you can see that the risk cutoff is 1 in 100, and you have a sensitivity of which is around 75%. The specificity is quite good. Now let us see what happens when the cutoff is increasing to say 1 in 300. Now when this happens, the sensitivity is increasing, but the specificity is also falling. That means the false positive rate will increase. Now we need to choose an appropriate cutoff where we can have a trade-off between the sensitivity and the false positive rate, and it depends on what kind of healthcare you have. For example, in UK, they have a publicly sponsored healthcare. So they use a cut of 1 in 100 so that they have a reasonable sensitivity of 75% and a low false positive rate because all the procedures need to be sponsored by the government. But coming to our country, we can't miss on a case of Down syndrome because we have to face the litigation and mostly the patients have to pay for the even for the care of the baby. So we go for a higher cutoff such as say 1 in 250, which gives us a sensitivity of around 85 to 90%, and the false positive rate in that case would be a bit higher. That would translate into more procedures. So the cutoff actually determines the sensitivity and the specificity, that is a false positive rate. If I had to summarize, if you use a higher cutoff, the sensitivity will be high, but the false positive rate would also be high. And it depends on the healthcare model that you're following.
Our next question was supposed to be on pre-test counseling, but we've already covered that excellently. Dr. Minu, why do we use intermediate risks and therefore a different cutoff? What is the logic behind that?
Is why when we're using the
Did we lose your connectivity? Dr. Minu, I think we lost your connectivity.
I know. I think she lost her connectivity.
Yes. Well, she's coming back. We're a little pressed for time. Dr. Sanish, can you take this question on this intermediate risk business? And you did introduce the topic, and we'll come back to this particular slide, which Dr. Minu will explain to us. But what I thought you could explain in the meanwhile is this, that we get to see, of course, Kypros Nicolaides, who gives us this chart, tends to change his mind every summer. But this is what he told us a few weeks ago. So this intermediate, what does it do? What does it shift to where that we are able to handle this?
Now, all the cutoffs that Radhamani madam discussed and we discussed are all mathematical cutoffs. So it doesn't mean that if you go in a low risk group, there are no cases of Down syndrome in them. In fact, 6% cases of Down syndrome are hidden in a risk cutoff of between 1 in 250 to 1 in 1000. And to pick all those cases, or maybe a greater proportion of them, we have what is called as a contingent screening. Seen in the slide is a contingent screening that has been proposed by Fetal Medicine Foundation UK, especially with the advent of cell-free DNA. So what here they do is, rather than keeping a cutoff of 1 in 100, they have kept the cutoff as 1 in 10. So all women who have a risk greater than 1 in 10, say for example 1 in 5, will receive a chorion villus sampling. And now women who have a risk which is more than 1 in 1000 will be categorized as low risk, and they will be followed with an anomaly scan. Now, all the women who are in between 1 in 10 to 1 in 1000, it constitutes what is called as intermediate risk. And there are certain cases of Down syndrome in this group. At present, the best test to offer in this category is a cell-free DNA test because of its very high sensitivity of 99.6% for Down syndrome and a very low false positive rate of 0.1 and a very, very low false negative rate of 0.02%. So this is what we call as a contingent screening, and maybe we have adapted it in a slightly different way in our country. I think it will be coming in the upcoming slides.
I wanted Dr. Radhamani's input on this. Should we just blindly follow what they're following at the Fetal Medicine Foundation, or how do we counsel our patients at the pre-test level so they find it much easier to accept an intermediate risk that we finally get?
Generally we do this aneuploidy screening for all patients because age-wise 35 year old, that is this risk cutoff is with the previous years only. Nowadays, because we are seeing about 70% of the Down syndrome we are seeing in younger age group. That is the reason why we universal actually we do the screening for all patients irrespective of the age group. And especially when there is a family history also, or whether there is a first pregnancy affected or any relative having. So definitely we will counsel the patient that this is the importance of doing it. And then by the routine conventional screening, trisomy detection is only 60%, and then They are varying between 60 to 75% when consider 18 and 13 also. But when we introduce the cell-free DNA, the detection rate is about more than 100% almost with a false positivity rate 5% is reduced to less than 1%. That is so if at all needed for a patient high intermediate risk patient. So high risk patient definitely we go for CVS or amniocentesis from 15 weeks onwards. Or else we for the integrated test we will do the previously we do the second trimester test also. So this we are doing a NIFT in our center when there is intermediate risk, and then we counsel the patient regarding this and the importance of doing this. And the only disadvantage is the high cost, and also they have to wait for another 14 days to get the report.
Yeah, thank you for that answer. Dr. Matthew, how do you handle this? Is it a very similar method in your practice, or do you have a revolutionary answer for us?
So the risk actually, the category which I follow is actually 1 in 250. If it is below 1 250, I take it as a high risk, and 250 to 1000, I take it as a intermediate risk, and about 1000, I take it as a low risk.
So would that mean that because it gives you a greater chance to do many more amnios and you won't get bored at work, or is there actually a scientific logic to this?
Now this is what I've been, I have set it as a protocol, and this is what I've been following.
Yeah. So it's not just the charm of doing much. What's the question of missing less and living with a litigious population? Would you agree with me there? That we try and miss as few as possible without getting scared of the invasiveness of a procedure.
Yes, sir. Yes, sir.
And would our presenter agree with that? Would Dr. Vidyalakshmi agree with me on this, that it's perhaps not such a bad idea to keep a relatively higher cutoff so that our intermediate would be between 250 and 1000?
Very tricky question, but unfortunately I have to answer you. 250 is of course fine because there should be some set standards, but keeping it less than that, I really am a little surprised and afraid, because maybe it will increase your false negativity. I'm really not sure.
Okay. We move on to this absolutely marvelous paper, which we'll take a couple of minutes before we wind up. And this is the pros and cons of these intermediate risk protocols. And there was this absolutely charming paper. Now, papers from China are not my favorite papers, but this has come out a few weeks ago. And two of these people are friends of mine, and I know that they're genuine researchers, Ling Pang as well as Daiwan Han. And they have come up with this absolutely charming method of sitting and calculating in the same population, different cutoffs and the costs. And this is a representative thing from them. And I was able to get the whole paper just a couple of days ago. And they worked out that if you use an intermediate between 1 in 50 and 1 in 1000, this would be it in terms of the overall costs, and then what would be their detection rate. And then they go through this chart. So I want each one of my panelists to handle one portion of this and tell me. So Dr. Sinesh, could you start off at the top here and say, what is really the difference between using this conventional fetal medicine foundation thing to say using a cutoff of 1500 or 2000?
I went through this paper, but I had not had a look at these figures. But on the left top, they have defined the intermediate group as between 1 in 50 to 1 in 1000.
Yes.
And they had a detection rate in that group of 88%.
Yes.
And I think in the intermediate group, they applied the non-invasive prenatal. I mean, they have compared different strategies.
Yeah.
And they have found that and when compared to when the intermediate risk was defined as 1 in 100 to 1 in 20,000, I mean 1 in 2000, they found that the overall cost, like the dollars, the amount of money that was spent was less when the cutoff was taken a little bit higher. When the intermediate group, the lower cutoff for the intermediate risk was set at a bit higher, like 1 in 100 rather than 1 in 50.
Yeah, and they did feel that, if we use our 250, 270 as a cutoff, we would end up imposing a larger cost. And okay, so we don't have to share it with, the government doesn't have to bear this cost in our part of the world. but really someone has to pay for it. And so we start wondering whether we should actually use a different cutoff and not go as high as 2000 and end up spending a more reasonable figure like we had over here, for instance, that we stick to 1 in 50 and perhaps stretch the upper to 1500. Would any one of my panelists like to talk about this stretching a bit to 1500 and therefore ending up really spending the least amount of dollars there? And should we actually encourage the government to compromise like this, or do you think that every woman really deserves this money from the government? After all, we're paying for keeping our borders happy, and we spend so much on defense. Why not spend on women's health? What would you think if we use a 1 in 50 to a 1 in 1500? Our cost is coming down a lot, and our detection rates are really very nice, 93, 94%. So how should we handle this? Would that be right? It's almost the same actually, even if we use between 1500 and 100.
No, can I put my thoughts across? Because most of these papers are coming from places where health economics is practicing, because it's done by the insurance, whatever it is.
Yeah.
But in a country where, as Radhamani Madam rightly told, in India, when the litigations are so high on, it is just not the government or the NHS which is funding. And the patient is willing, and if she understands the pros and cons of the what are we talking about when we are talking about intermediate risk, NIPS bringing it close to 99+% to detect trisomy 21. But do you really want to compromise on setting your standards of intermediate risk to higher values? Something you need to answer.
So do we have a consensus on this, that we should use a relatively lower cutoff in terms of the lower cutoff and a little higher, like instead of using a 1 in 50, perhaps a 1 in 100, and instead of using 1000, maybe 1 in 1500? Would that be a better idea? Or do you think that we should actually just leave it to the patient, saying that, look, this is what might happen, what we might miss, and not use sharp cutoffs mathematically imposed upon biology, and let them decide?
Yes.
And we use them as a guidance for ourselves, but the ultimate decision is with the patient. Would this pattern be okay? You can put your hand up if you agree with me, and then you would say, Dr. Radhamani, would you agree that we should use this cutoff of 1 in 100 to 1 in 1500 perhaps, and let the patient decide without imposing too much of mathematics?
We need to tell the patient about this matter, and they can also decide about this. Number one, actually in India, in intermediate risk, we are considering as a 1 in 1000, and I have seen papers also 1 in 51 to 1000. 1 in 51 to 1000 is the intermediate risk, and more than 1000 is the lower risk. The problem is actually the advantage of doing for self-DNA is that if it is positive, then we can offer for the inverse test. If it is negative, and then there is a reduction in the about 70% reduction in invasive procedures. So that is advantage. Another advantage of cell-free DNA is sex-chrome abnormality also we are able to diagnose, and also triploidy. That is a great advantage of going for cell-free DNA. But of course, we need to tell the patient, because again the result can be for the failure rate or the too many factors also will be affected. So that also has to be considered, like obesity when the patient is on low molecular weight heparin, when IV procedure, all these factors, and even the sampling error, how do we store, and all, there are different methods, and all. You people may be knowing better than me. So these are also to be, we need to tell to the patient that this is, but what is advantage? Always we should tell the advantages rather than the disadvantages, to make them aware the importance of doing all these things. Otherwise, there is a waste in telling all these things and all.
Thank you so much, and my thanks to the panel for all their marvelous inputs. We leave it at equipoise, which is that we will keep the mathematics flexible, and we will keep the options flexible until we have more information. And I did miss Dr. Meenu Batra for her inputs, but I now hand over the floor back to the organizers for moving on to the next case. Thank you very much, panelists. Thank you for being here tonight.
Thank you so much, sir, for breaking that clinical equipoise. At least it has created a lot of discussion about cutoffs and And it's very well taken that we have to rethink on where we put our cutoff, especially in this era of NIPT, where we can reduce the number of invasives as well, which is not seen in that paper actually, because the number of invasives that go down when you bring your cutoffs down are also high. So we'll take a small sponsor break, and then after that we will go into the next one, which is about TTTS. Vishal, if you can. Welcome back again. Can you see me? Yes, welcome back again, and we go into the next clinical condition that creates a bit of confusion. I know all of you know that TTTS is a condition in which laser is the treatment of option. There is no confusion on that. But there is a little bit of equipoise when it comes to stage 1 TTTS, with two groups across the Atlantic fighting about whether you need to actually go in and do a laser procedure in stage 1 TTTS, or whether we should go the conservative route. And for that, I have Dr. Vivek, who is a good friend of mine and a brilliant speaker, and he will take you through a case of stage 1 TTTS and how they've managed it at their center. And after that, we will have Suresh sir, who's actually a person I don't need to introduce at all, and who's been an inspiration for all of us in fetal medicine, and who will actually go through this case and tell us whether we need to intervene or not in stage 1 TTTS. Vivek, over to you.
Hello.
Yeah, you are audible.
Okay.
You can maximize the screen.
Yes.
Perfect. Perfect.
Right. So because we're running a little late, I'll dive straight into my case and then try and swim as fast as possible. So this was a 39-year-old second gravida who came to us with a previous normal delivery, 7 years age. Child is doing absolutely fine. She came at 21. I mean, she was referred at 21 weeks and 5 days of gestation as MCDA twins with suspected TTTS for intervention. Cerclage was done before referral because cervix was apparently short. And despite her advanced age or advanced maternal age, she had no comorbidities during this pregnancy. Now, on quick survey, on placing your ultrasound probe, what strikes you is that you see a little bit of polyhydramnios there. You see one fetus that is actively moving on the right, which I've called here as A because that was how it was labeled before referral. And the other fetus looks as if it is not moving much, and you don't see a very distinct intertwin membrane. So at one go, we're very tempted to just call this off as a monochorionic monoamniotic twin. But the lack of movement of this twin is a little bit of raises a little bit of suspicion. So you would definitely want to look further ahead. And now, indeed, if you look further ahead, you would see that this baby does. I mean, there is indeed an intertwin membrane that you see here, and very clearly you can see that this baby is suspended as if in a hammock with very little fluid. You can see the difference in echogenicity between the fluid that you see on this side of the membrane and the fluid that you see within the sac. So essentially, you have a baby that is suspended in a membrane with very little fluid on this side, and a baby is freely moving about with plenty of fluid on the other side. Now, again, if you see, this baby is really not stuck, even though in the first video that I showed, it looked as if it was not moving. If you look closer enough, you would see this baby is actively moving. It's actively flexing and extending its knees as well as its elbows. So there is a little bit of fluid for it to move around. And certainly it is buoyed by the fluid on the other side of the membrane. So it is indeed actively moving. Still not what you would call as a definitely stuck twin of TTTS. And if I were to look closely and actually measure this amount of fluid that is there in the sac, you would see that there is a decent amount of fluid, not as low a fluid level as we thought at the first survey scanning. There is indeed a decent amount of fluid. And if I measure this sac had 3.1 centimeters single deepest pocket, whereas the other one had a pocket of 13.2 centimeters. I ventured to look at the growth of the fetuses. The fetus that had normal fluid, or rather increased fluid, had normal growth, whereas the other one that appeared to be having a little bit of less fluid around it had short and a smaller growth as well. You can see that the growth is much less compared to this twin, and of course there is a fetal weight discordance of around 28% that you are seeing here. The same thing is shown on the graph. The fetus A that had the polyhydramniotic sac is growing normally, whereas the other one has got a lot of catching up to do. If you look at Dopplers, again, the larger twin was growing normally with normal Dopplers, whereas the smaller twin had an umbilical artery showing high resistance flow 94, but definitely positive end diastolic flow, no absence or reversal. Again, the other thing that we need to look at in such cases is the bladders. You can see that both bladders are concordant. There's no distended bladder in the polyhydramniotic sac, nor is there an absent bladder in the oligohydramniotic sac. Placental surface, if you see, it is still not the kind of flattened out placenta that you would attribute to severe polyhydramnios. Mind you, when there's severe polyhydramnios in one sac, the placenta gets completely flattened out because of the increased intraamniotic pressure. So that is still not seen at this particular point in time. You could see those nice curvatures there on the fetal surface of the placenta. Again, we do a sonographic mapping in all such cases. Here, if I were to draw this on a picture, this is the syphilis sternum, this is emphysis pubis. The placenta is slightly off the midline towards the maternal left. This is how the donors of the intertwined membrane was looking like. The donor was stuck or reasonably stuck here to one corner. This was a donor cord insertion. This was a recipient cord insertion. That is the umbilical. So this is how we mapped the placenta at first visit. We also mapped the placenta to try and look at what are called as artery to artery anastomosis in the surface of the placenta. Now, the importance of this, I'm sure Dr. Suresh would come to in the discussion part of this. Now, in this particular case, we could not identify any significant artery to artery anastomosis on the placental surface while mapping. Now, with these findings, what would I call this pregnancy as? There is, mind you, as I said before, there is a 3.1 centimeter pocket in the oligohydramniotic sac. So you cannot technically call it oligo. To call it oligo, the sac has to be less than 2 centimeters in diameter in single vertical pocket. And because you have 3.1 here, you have poly on the other side for sure, but you don't have oligo on this side. So technically, you still cannot call it as a twin to twin transfusion syndrome, because to call it a stage 1, you need at least a pocket of more than 8 centimeters in the recipient sac, which is what you have here. But the other sac, the so-called oligohydramniotic sac, has to have a single pocket of less than 2 centimeters, which is not the case in this particular scenario. So we yet to call it a stage 1 TTTS. Rather, we would call it as selective fetal growth restriction at this point in time, because the donor weight is below the 10th centile and there is a discordance of more than 25% between the two twins. So what you could call it at this point in time is SFGR, and because there was positive end diastolic flow in the umbilical artery, you would call it as type 1 SFGR, but I would, of course, definitely put in a word saying that this could evolve into twin-to-twin transfusion. You might even want to call it as pre-TTTS or evolving TTTS for sake of follow-up. You would definitely want to see these babies back in less than a week's time, which is exactly what we did. We saw her 5 days later, and now you could see that the sac that had less amount of amniotic fluid, the baby's relatively stuck now. It did not have the same kind of mobility it had 4 or 5 days before, which is a clear sign that the liquor in this particular sac is coming down significantly. And if I were to measure this single pockets in these two sacs, it came down from 3 point something to 1.95, less than 2, whereas the other sac had marginally gone up from 13.2 to 13.9 centimeters. So now there is oligopoly sequence that is there in this particular pregnancy. Again, if I were to draw this on a graphical representation, this is how the pregnancy, the fetuses were looking like. This is the mother's abdomen. My probe is here. This is the cross section. This is the right. This is the left. The recipient sac was on the left side of the mother. This is the placenta. This is how the membrane was wrapping around the donor twin, and the donor twin was kind of stuck at one corner of the placenta. So this was the picture that we had in mind. Again, the bladders were still very much concordant, but having said that, if you look very closely at the donor bladder, on 4 different occasions, the donor bladder, here you hardly see one, here you see a decent sized bladder, here again it's a very small bladder, here somewhere in between. So it was not a steady bladder that you were seeing in the donor fetus. It was kind of transient, it was small, and it was tiny in some cases, and this is the only case where we saw a reasonably sized bladder. So it was a fluctuating tiny bladder, a transient bladder that you were seeing in the donor twin. Now the Dopplers again, mind you, in the previous scan, I mean 5 days back, this Doppler, the umbilical artery Doppler in the smaller twin was above the 90th centile. Now it had come down to just below the 90th centile. But again, you would expect to see such fluctuations happening in TTTS. So technically, this would be called as concordant Dopplers because there is no high resistance flow in the donor twin on the smaller twin as of now. And as a policy, we do a fetal echocardiography for cardiac functional assessment in all these cases. And in this particular case, you would see that there was significant biventricular hypertrophy, particularly of the left side of the heart, and no structurally significant no significant structural cardiac defects. Whereas fetus B, with whatever difficult images we could get because of the oligohydramnios, there did not seem to be any major cardiac compromise. So now technically the normally growing twin sac has a Leica pocket of 13.9 and the other one has a Leica pocket of less than 2. So technically you could now call this as stage 1 Quintero TTTS. So to summarize the case, this was a 39-year-old second gravida at 22 weeks of gestation, monochorionic diamniotic twins, even though we had initially suspected a mono twin pregnancy. There was definitely a membrane that we could identify, and there was decreasing Leica in the donor sac. The twins were discordant for growth and Leica, but concordant for bladders and Dopplers. And technically now you would definitely want to call this as twin-to-twin transfusion syndrome stage 1. But again, as I said before, I would add a footnote here saying that the bladder in the donor is tiny and transient. This mother had a short cervix, and which is why a circulage was put in for her. There were no demonstrable artery-to-artery anastomosis that we could identify on the surface of the placenta. There were signs of early cardiac dysfunction on the recipient with a CHOP score of 6. And there was mild maternal distress. She was finding it difficult to lie down and breathe normally when she was lying supine. So this is a footnote that we would add to the report of or a diagnosis of twin-to-twin transfusion syndrome stage 1. And over to Sir for the discussion.
Okay. Thank you, Vivek, for that lovely presentation. Can you make me the presenter? Okay, I hope you're able to see my screen. So the question is, Vivek has presented a case which is classified as stage 1 TTTS, and we need to make a decision whether to treat this baby or do expectant management, or if you decide to treat, what kind of treatment that will be required. We are quite aware that 9 to 10% of MCDAs will have TTTS, And the anastomosis are of three types. The AV anastomosis, which are deep, and AV can go from one baby to the other and the other baby to this side. So they usually both balance out each other. And there are also superficial arterioarterial anastomosis, which serve as balancing anastomosis. The problem in TTTS is the imbalance of flow, the recipient having more volume, polyhydramnios, and cardiac overload. And so let me quickly go to the panel. And how is TTTS diagnosed in the first place? And who would like to take that question first? Doctor? Hello, my panelists?
Yeah, I'm Dr. Maya
please.
here. Actually,
please.
he has already diagnosed the case. He has already given the definition of how TT stage 1 TTTS is diagnosed.
Yeah,
So,
the question is, the Quintero staging has been in existence for quite some time now.
Yeah.
Can you tell us why is it required at all in the first place? See, if you see an oligopoly, where Vivek has shown us, then automatically we know that this is TTTS. But why is Quintero staging actually required?
actually, to first of all, to manage the patient and to prevent neonatal morbidity and mortality, if at all possible, through intervening by the fetal medicine specialist. That is the most important thing. As obstetricians, we'll be thinking about seeing TTTS. So evolving of TTTS from stage 1 to stage 4 or 5, we want to arrest that at the early stage itself. So that is the main reason why we need the staging.
Yeah. Pratima, would you say that Quintero staging is absolutely essential and we need to follow in all cases, and all our management is going to be based on Quintero staging only? Is Pratima there?
I don't think she is there.
Oh, okay.
Question?
Yeah.
We cannot hear her.
So,
I will take the question. I'm Jyoti Manjeri here.
Yes, please.
So the question is, do we really need Quintero staging, isn't it?
Yes.
Quintero staging is the simplest staging system which we have, with which we can prognosticate the twins. The second part of the question is, do we have to stick to Quintero staging in terms of treatment? So across the world, I think there should be an uniformity in managing the TTTS patients. So Quintero we don't have any other modality which is proven to be better than Quintero staging, but we do know that there are faults and demerits for Quintero staging.
Hello, yes. I can see everybody and I can hear myself. I don't know why others couldn't hear me.
Yeah, we can hear you now.
Okay, because I was here all the time. Yeah. Okay.
Yeah, we can hear you now.
Yeah.
So
I think Jyoti has answered. I think.
Yes. Yeah.
I think Quintero staging personally, and just to add to what Jyoti said, it is very we have some sort of a, especially when we are talking about treatment between units. We heard in the first case where the FGR equipoise problem is nobody knows how to, there is no clear-cut guidelines on defining FGR, but there is a clear-cut guideline on defining TTTS. And when you stage it, when we talk about treatment, when we talk about research studies, when we talk about protocols, we know that if somebody is telling me this is stage 1, I know that the bladder is C. If we say stage 3, then I know that there is abnormal Doppler in one of the features. So I think exchange of information,
more like a definition and then take through. Yes. Okay. So, Pratima, can we define stage 1 better? And does it differ with gestational age? The definition of stage 1, and what about the growth of the twins? Is growth also considered as part of this, or it is not considered as part of
growth? Well, I'll go in the reverse order. Growth is not considered as a part of TTTS definition. That is a separate entity altogether. In Vivek's case, we had growth there was a discrepancy in growth along with TTTS, which I think is more to do with chronic TTTS rather than acute TTTS, because you get growth discrepancies in chronic TTTS. And I mean, you can say it can be SFGR, because sometimes SFGR and TTTS can coexist as well. Differing with gestational age, no. Fortunately, there is one definition of TTTS, and it just stays right through the pregnancy. And I think the only thing in the early parts, because I just saw some recent papers where before 20 weeks, the 2 and 8, and before 16 weeks, 2 and 6 were the polyhydramnios. So just about this, there's not a lot of variation. But now, because we are doing treatment even earlier than 18 weeks, so it's coming down, the 8 is moving down to 6 at below around 16, 17 weeks. So that's the only one change that I see. So I think that answers your question. I think all three of them.
Yeah, Vivek, just another question. In the case which you had presented, would you give importance to the cord insertion sites? And would that also help you?
Definitely, sir, because that is going to tell us what to expect in this particular case. I think I missed out on that slide. There was one slide on cord insertion. I think I showed it in the mapping picture. So we would definitely look at cord insertions at 16 weeks, if not.
No, I'm talking about if there's a velamentous insertion of the cord or no velamentous insertion of the cord. Is that something you look for in all the cases?
Definitely. Velamentous insertion, margin insertion is something that we really look for too, because these babies are known to go in for selective growth restriction as well as a component of treatment.
So there's an overlap of a growth problem and also a TTTS. Where we are concentrating on the TTTS, we need to understand the implications of the treatment for the smaller baby as we go by. Now, obviously, this is where the bladders are seen. Now, one of the interesting things that you showed that baby was the bladder was very small, and then it sort of became absent and became very small. The question is, should we do Dopplers in stage 1 when the bladder is obviously seen? Should we do Dopplers at all, and what Dopplers are to be done, and what are the expected results? Anyone can take it. Anyone can take it.
I can take it. I think Doppler should be done to define the stage, because although we have reasonably strict criteria to define the staging in Quintero, it is not uncommon. It is not uncommon for us to find a small fetus with a small bladder but with abnormal Doppler. And you can have a baby with an absent these are the atypical stages, and atypical can happen in all the 3 stages, stage 1, 2, 3, less likely with stage 4, but stage 1, 2, 3 you can have atypical and cross changing. So I think, because if you have a small bladder, tiny bladder that you think with severe oligoamnios, and you have an abnormal Doppler, then you are thinking more in terms of stage 3. You will not call it stage 1, and then you are more likely to do a laser sooner rather than later. So I think Doppler should be done irrespective of the for all monochorionic twins.
But and obviously you expect the Dopplers to be normal at this stage, isn't it?
More likely, yes, if you have a reasonably good bladder with amniotic fluid. But sometimes you can see absent bladder without much amniotic fluid. Right? In that case, I would be very skeptical whether the Doppler would be normal. But check it a few times.
And
what I would say.
What about evaluation of the heart?
Yes. So
I think it's very important to evaluate the heart.
Yeah. So
especially the recipient, because it's not uncommon to have reduced contractility in the recipient, because that is also an indication in stage 1 for treatment if you have these atypical presentations.
So we'll come to the treatment part. So routinely, once you see a like a discordance and you're probably suspecting stage 1, automatically you will go and do evaluation of the cardiac evaluation especially for the recipient, isn't it? As part of the. protocol.
And
So
Dopplers,
the MPI
Dopplers
yeah.
also could be used to, as you said before, sir, to map the cord insertions. Again, you would need Doppler. Again, to try and look for anastomosis on the surface of the placenta, you would need Doppler. So it's not just the peripheral Dopplers. I think cardiac assessment, to look for anastomosis, all that would be, I mean, you would need Doppler.
Yes, agreed. So now stage 1 TTTS, the definition is a little ambiguous. Do you agree with me on that?
Yes.
Absolutely.
Because the bladder in the donor, what Vivek showed, why not it could be just old urine, or it could be due to low production, which we know that's why the oligohydramnios comes in. But this paper actually showed us that this small bladder which you see could actually, you can't classify it as a bladder present because it could actually be stage 2 instead of stage 1. And that's the difficulty in making the diagnosis. And 50% of recipients showed abnormal myocardial dysfunction, but normal peripheral Doppler.
Yes.
Now, this clearly shows what Pratima said was the importance of looking at the heart and the recipient, because the primary problem is volume overload. And the volume overload can be the first manifestation before you can see other manifestations. Right. The next question is, does stage 1 evolve to stage 2 always? Now, Jyoti, can you say that?
The answer is no, definitely. But I think we have enough evidence to say that there is evolvement of stage 1 to stage 2 in at least 10 to 50%. And the recent RCT, I think they have quoted as 60% progress from stage 1 to stage 2. But there are at least 40% who will remain in the same stage or regress back to normal.
Okay. And anything else anybody would like to add on this? And how long does it take to evolve, if at all it evolves? Because we need to...
The relative fraction of cases that progress and regress have varied across the years over the papers. If you see, some have said 30% progress, some said 25% progress. Recent papers put it more at 50, 60%.
So can we all agree, but can we all agree this is exactly an equipoise situation?
Absolutely.
Yeah.
Absolutely.
In fact, it may not even evolve to stage 2. It might just jump to stage 3 straight away, or even stage 4 for that matter. So it does not follow. I think this is the criticism of Quintero staging, that it doesn't follow 1 to 2 to 2 to 3, 3 to 4. It can go from 1 to 5. It can go from 1 to 4. It can go from anywhere, literally. But generally, if it graded again, if it goes, it just goes.
So in this paper just published in 2007, 132 had TTTS, 46 had stage 1 disease, 28% were stable, 41% regressed, and 39% progressed. So the question is, in stage 1, you are deciding, let us say for this case, and you are deciding to wait and watch. And so how frequently would you like to call this patient back?
I think generally the ones that progress tend to progress within, I'm sorry, is a question for Maya, madam?
No, it's okay.
Generally what we've seen in practice and what the literature says is that if these stage 1s progress, they do progress within the first 2 or 3 weeks. So, which means your window for follow-up has to be tight during that 1 or 2 weeks, within which you would know which way it is going. So if it's progressing, it generally progresses within 2 weeks. So I would want to see at least twice a week, if not more frequent than that.
Okay, Dr. Maya, let us say this patient is coming to you in your practice with stage 1, and you are quite remote from any major center, and the access to treatment is not available immediately. Would you call her back and watch for progress to the next stage, or would you say now go to the higher center immediately?
I would advise the couple to go to the higher center immediately, because it can progress, as Vivek said, in a couple of weeks' time, it can progress. So it is, I wouldn't keep her like wait for progression rather than, I would
Very good.
send.
So this is going to be a preamble to another question which is going to come later on. So anyway, so the ideal monitoring is about weekly or even bi-weekly. Of the cases that progressed, 79% did so within 2 weeks. So we expect, because what happens is when patients travel from one place to the other, they are going to ask, how long should I be staying here from wherever I am? And it's a question of relocation to a different place. And everybody is not able to relocate over a very long time in another location. So, so 93% progress to at least stage 3. That is those which in the ones which progressed, they, as Pratima said, they progress to stage 3 directly. So that's why it's important to monitor. So now question management. What is the kind of consensus we can come for this management? Expectant, selective laser photocoagulation, or selective reduction? We'll take the choice of each of the panelists, and then we'll say, starting with Dr. Mancheri.
Each management has got its own benefit and demerits. So as of now, with the current business, I think expected management does have a role, provided we can categorize the stage 1 into a high risk and low risk group. So basically, I'm quoting the recent RCT, which started way back in 2011 and released in 2018. So what they have concluded is at least 60% will progress to stage 2 or higher, but those patients who remain in stage 1 on expected management, they've got fantastic outcomes. So there is a role for expected management if we carefully select the patients.
So case selection is important. Okay. Next, Dr. Maya.
Yeah.
Would you agree with her?
Yeah, I agree with her. But definitely, these patients should be managed by fetal medicine specialist.
Okay. Pratima?
Yeah, I think I agree with that, because I think also there was another study done by Dr. Anita Cole's group, which was present in IFMSS meeting a couple of years ago, where they looked into the stage 1 TTTS, and they say, and pretty much similar results, where 1 out of 4 progressed, 3 out of 4 did not progress, and they remained like that. So I think, like in Vivek's case, we saw the progress within 5 days. Within 5 days, that babies, there was a change in the cardiac function in the second baby. So I think the first and the after the first, the second follow-up should, I think, be very quick, and like 5 days, 4-5 days, or at least certainly within a week. And if you see progression there, then I think the decision is really made to go ahead with the treatment, particularly if the cardia of the recipient is being affected, because then you're clearly cut on the road of coagulation. But if it remains stable for at least 3 to 4 visits, then I think you are probably looking at an expectant management. Selective reduction, not unless if there is an anomaly. If there is an anomaly, then yes. Or if there is a severe fetal growth restriction where you have absolutely no hope for the smaller baby, then, but I wouldn't recommend selective reduction for TTTS.
So the question is, the counseling this patient becomes a challenge at stage 1, where you yourself are debating between expectant or management. You've not made a decision. What do we tell the patient? What do we tell the patient in terms of?
We need to take each patient individually and assess their risk scoring. Basically, if they're symptomatic, or if the discrepancy is quite high, or if they have short cervix or contractions, we need to counsel them in that way. And if they're stable and if we can clearly see the bladder, the Dopplers are fantastic, there is no tricuspid regurgitation, cardiac functions are all normal, then we counsel in a different style. So depending on what they come with, we need to counsel them and advise them accordingly.
So can I just add one thing?
Yeah,
can I just add one thing? Yes, their economic status is also very important, because we are going for all these treatments and all if needed. So we need to counsel them regarding the cost.
Yes. So the question is, one is, here is a group of patients would get away with expectant management, but with very frequent follow-ups. Another group of patients will go from expectant management to selective laser. All I want to know is, right at the beginning in the first sitting, would you tell them that at some point of time you might require a laser, or we'll say we'll wait and watch, and then tell them that, oh, now you require a laser at this point of time?
I think we need to give them enough warning that the plan is to go for expectant, but at any time they can progress and we might need to move on to the other laser procedure.
Yeah, I think it's very, very important. Okay,
So
so
I just add a word for the counseling. I think counseling in monochorionic twins should start at the time that you diagnose monochorionic twins. That is at first trimester.
Yes.
And the mental preparation, the emotional preparation, and of course the financial preparation should start from the point where you diagnosed. Because at that point you say 1/3, 1/3, 1/3. It's a simple equation. 1/3 will go on to have complications. 2/3 will not have complications. The problem is we don't know who will have complications and who will not. So you have to be prepared for this.
Yeah.
And I think if you motivate the patients, they are much better prepared. And many times we have to make decisions to do a fetoscopic laser at the drop of a hat. Like you see them in the morning and evening, you have to do a laser. And in these kind of patients, they're not prepared. In fact, yesterday I had a patient who was given a 2 weeks gap after diagnosing stage 1 TTTS. And by the time she came, it was massive polyhydramnios. And by the time she went back to her obstetrician, she delivered. So there was hardly any time to, this is at 24, 25 weeks with a beautiful posterior placenta, completely normal Doppler, everything beautiful, would have been a perfect laser, but had a cervix of 5 millimeters. So very unfortunate. So, and this is only in 2 weeks with no discrepancy in weeks, no discrepancy. It could be very fast. And if they're not mentally prepared, I think it becomes very difficult. So counseling should really start at the time that you first know that they are monochorionic.
So we will still call stage 1 as a potentially emergent situation at any point of time.
Yes.
Right. Now, next is to decision to intervene. Now, is the decision to intervene based on the bladder of the donor, based on Doppler, or based on liquor in the recipient sac? Vivek, you want to take this?
Yes, sir. Again, these are the inherent ambiguity that you have with the definition of stage 1 TTTS, because as you rightly said, when they say bladder is present, they do not mention whether the bladder is small, transient, or absent, and keeping on going and coming. Again, Dopplers, as you said, the Dopplers may be normal, but the cardiac Dopplers may be bad. Liquor in the recipient sac, again, gives you an idea of what the maternal distress chances are, but again, is not a real indicator of prognostication or a guide to intervene. That is where we start thinking in terms of do you really need to subtype stage 1 based on these parameters? But having said that, again, you're not very clear as to what parameters are associated with a poorer chance. Higher chance of progression. Is it small bladders? Is it increased body? Is it
I'm going to play the devil's advocate here, and I'm going to ask Pratima. I will say that in stage 1 TTTS, I saw her 5 days ago. The liquor in the recipient sac was, let's say, 9, and then 5 days later, it became 13. And the bladder is still seen in the donor. And but because it has gone from 5 to 13 within, from 9 to 13 within 5 days, I'm going to intervene irrespective of anything else. Is that a good argument? Because over distension of the uterus.
I think if it comes from you, I would say yes, that's a reasonable argument, because I would presume that you would have seen the heart of the recipient. You would have seen the, what is happening to the liquor in the donor sac, because here it is increase in the recipient sac, but there has to be simultaneous decrease in the donor sac as well. And number 3, you are looking at the maternal cervix, which is showing some evidence of shortening. And finally, you would look at the mother. Is she uncomfortable? I think these are clear-cut signs to me that even in stage 1, you would need to intervene.
So my question is, let me go back to Vivek's case. And he showed us first 3.1 and 9.5, something like that. So 3.1 and 9.5. And so why was not an intervention considered at that stage itself? Vivek?
Yes, sir. So pre-TTTS, even with stage 1 TTTS, we're looking at somewhere around 50% chance of resolution. Where with the complete expectant management, you can have very good outcomes. So I would not want to subject a lady.
So this 2 centimeters in the donor sac seems to be a Lakshman Rekha, isn't it?
Because you need to draw a line somewhere. Based on which you can
That's what I'm trying to say.
I cardiac function
Yes.
was, he has mentioned that the cardiac function was normal. It was just a discrepancy in the Leica at that point, and the bladder was
Yes.
clear.
Okay.
Yeah, so generally, I
Right.
think indications for intervention in stage 1 would be, as you said, severe maternal distress. Definitely, we don't have a choice. We have to do something. Or if there's a
So-
very short cervix that is related to the polyhydramnios, again, you would probably want to intervene.
Yes.
And apart from these, or if there's a cardiac dysfunction, as Jyoti ma'am said, you would definitely want to intervene. But apart from these, I would still want to wait, because one, looking at stage 1 parameters, you really don't have predictors or markers of which of these are going to predict progress to stage 2 and beyond. And on the other hand, if I wait, I still have an 80 to 85% chance of a normal outcome with expectant management if it remains in stage 1 or regresses. So I would not want to subject a lady to an intervention which carries a risk of procedure-related losses, unless I'm absolutely sure that this is going to progress. Or in stage 1,
now,
if there is a definite indication from the maternal side, or there are very distinct signs that this is going to progress, as we saw in this case, a very small bladder, increasing Leica, and worsening cardiac function. All these going to tell you that probably in a week's time this is going to progress into stage 2 or 3. So then, which is what happened in this case, incidentally, which I didn't mention. This eventually progressed to stage 3, and we did do a laser for this baby, and for this pregnant.
So let me. We spoke about two options of management: expectant and laser. But there's a third option of management, which is amnioreduction. So why would we not consider, supposing this place, the patient is a very remote place, they don't have access to any facility, and the only management they can do is to do expectant management. So is amnioreduction an option?
Well, amnioreduction would be an option if laser is not an option.
I'm talking about stage 1.
Yes, sir. For stage 1, if you decide to intervene, then the option has to be a straightforward laser if you have the facility to do it. But as you said, in a remote center where they do not have an access to a nearby fetoscopic center, then I think in such cases, probably amnioreduction might have a role. Or else, if she's quite late in gestation, 28 weeks, 29 weeks of stage 1, again, you could do an amnioreduction.
Yeah, Pratima?
I think one has to be very careful about doing an amnioreduction, because there are two very important issues. Because there is, if you say that it comes from a remote place with no expertise for amnioreduction, by doing serial amnioreductions, you end up with, disabled children. Will that same remote place have the ability to look after these two children who are severely disabled? And I think this is a very, very important question that remote places have to answer to themselves. Number one.
Correct.
So I think sometimes not doing an unnecessary treatment, or not doing a treatment that could potentially harm is far more dangerous than doing a treatment, right? Secondly, I think by doing an amnioreduction, you're only delaying the procedure, the fetoscopic laser, and it actually makes the laser procedure even more difficult.
Difficult.
Right? And yes, it is, and that is again, those papers have come from the US as well, where they have shown that procedures, lasers that have been done post amnioreduction have a much higher chance of infection, which is understandable because they have got already, because you'll have to do an amnio infusion, and doing an amnio infusion will again carry the risk of infection.
Exactly.
So it is not serving the purpose. So I think I am not at all a propagator of amnioreduction.
Okay, so this survey, which was an international survey, they took data from 76 centers, 48 from North America, 20 from Europe, 8 other continents. And amnioreduction, 11% of the centers reported amnioreduction for stage 1. And they were all from the USA, right?
Thankfully.
None of the European centers, none of the European centers did that. And most of the European centers were preferred laser, right? And of course,
or expectant management.
Yes. So so the question is, if you are a laser center yourself, or you don't have a laser in your place, so would your decision change based on that? Having the facility, would you tend more to do the procedure rather than delay?
In fact, less. I would say you're less likely to do, and I think that's what your paper shows as well. You're less likely to do a laser.
Why is that? Why is that?
I think because you know where the laser will have a good outcome and where you know the laser is not going to have a good outcome.
Yes.
Like, for example, the lady who came yesterday, I mean, I mean, thankfully now because of the COVID, you have to wait for 48, 72 hours anyway before you do the laser. But whilst waiting, she just went into labor and things. So had I put in a scope immediately, she would have anyway miscarried.
So it would have been a procedure-related loss.
And then it becomes a procedure-related loss. So I think, and of course, laser centers probably see more monochorionic twins, and they have got this gut feeling. In fact, I wanted to ask Vivek, what was your gut feeling when you saw the patient the first time and the second time? Because why did she come within, like, in 5 days? You know, probably your gut feeling thought that there was something that is happening there and bring them back sooner rather than later. So I think
yes. So the next question is cervical length. How important it is to look at cervical length in stage 1, even if you're going to do expectant management? Is it important, and will that influence your management?
Yes.
So if I may interrupt, we are
Yes.
just running out of time.
Yeah. Last question. This is the last one. Yeah.
I think cervical length does not really depend upon stage. So whatever stage of TTTS it is, if your cervix is short, you need to put in a stitch.
Okay, right.
Can I am very skeptical. I mean, I wanted to bring that up because I would like the opinion of other people who do lasers as well. My experience with cervical stitches before doing the lasers has not been good. There's a much higher risk of chorioamnionitis in these pregnancies. And I always prefer that the stitches put after the laser. I think the problem we are facing here is prophylactic stitches being put the moment they diagnosed twin pregnancies.
Yes.
I mean,
I completely agree with you.
It's a disaster waiting to happen if I have to do a laser on people who have had stitches.
Yes, completely agree. We should not do stitches. Okay, just quickly close the session because I run out of time. The expected outcomes are short-term survival at birth and long-term good neurodevelopment. So in stage 1 TTTS, you find the survival to discharge was 82%, 54.8% amnioreduction, 9% at progression and laser. Now you do amnioreduction when it is already quite after 26, 27 weeks. You just want to buy some time to go through to delivery. So just to say that laser perinatal survival of at least 1, in 40% had laser, 85% at least 1 survivor, 65% both survivors. Long-term neurodevelopmental impairment was in 0%. Whereas in expectant management, there was 23% long-term neurodevelopmental impairment. So this paper says, well, even in stage 1 TTTS, you should do laser because the chance of neurodevelopmental impairment long-term outcomes are much better if you do laser. So this is what we call as equipoise now. There are 2 groups to say do laser, better long-term outcome. So I think we will close here. I think it's we've gone past our time. And then the only thing I wanted to tell about the challenge in India, as we already discussed, that patients living very far away, going and coming back and forth, that's when the decision making to be more precise for them. When they travel to a remote location, they want to have the procedure quickly and go back. But after going back, the post-laser management is also a big challenge. That is looking at Dopplers and making decisions on that is a very, very significant thing, which we'll probably take it up on another session. So thank you all panelists for this wonderful session. Thank you, Meenu, Bijoy, and the CMAR group for this lovely session. It's a great idea. Thank you.
Thank you, everybody.
At least we got in some very good ideas on this equipoise that we have in stage.
Thank you, everybody. Thanks all the delegates as well.
Thank you. Thank you. We go to the last condition of clinical equipoise. We talked about IUGR, we talked about screening, and we talked about TTTS. Now we go to something more close to imaging. And that's when we find an imaging and then we are in equipoise as to what do? Do we directly go in for termination when you get an abnormality as bad as an ACC, or do we do more and try to answer the question as to whether continue the pregnancy in an isolated ACC or not. And for that, we have Dr. John, who will be present, who is a radiologist from Trivandrum and who is doing excellent work in fetal medicine, who will be presenting a case on ACC. And then we have none other than the person who is the person to talk about CNS abnormalities, and that's Ramurthy sir, who will be guiding us through the management of agenesis of corpus callosum. Over to you, John.
Am I visible? Okay. So my case is about a 22-year-old lady, gravida 2 para 1 living 1, a previous full-term normal delivery 2 years ago, a healthy 3.1 kg male baby, now spontaneous conception. There are no risk factors in this pregnancy. FTS was low risk. She didn't do her anomaly scan at 20 weeks because of her local area being a containment zone, and she did a scan around 23 weeks and in a local center where they diagnosed mild ventriculomegaly, and she was referred at 24 weeks for a second opinion. And truly there was borderline to mild ventriculomegaly. On the right side, the atrial width was 11.6 mm, and on the left side, it was 9.8 mm. But what was also striking was the abnormal shape, size, and symmetry of the cavum septi pellucidum. And this is the axial sweep. It's a transabdominal scan. The baby was in breech presentation. I will just slightly run the video slow for a better visualization. You can see the frontal horns are pointed and well apart, widely separated. Can you hear me? And also there is there is the colpocephaly, which is prominently seen. So I'll just quickly go through a few bookmarks. One, the pointed, widely placed anterior horns. This is a view juxtacephalad to the transventricular plane. Again, an abnormal shape, size, and symmetry of the cavum septi pellucidum. And again, this is the Sylvian fissure. I'll just go behind. Normally, you at 24 weeks, you expect a 90-degree angle, somewhere like this, 90-degree angle along the posterior lip of the Sylvian fissure. Here, as we can see, the angle is slightly obtuse. We need to follow this up. Once you see an abnormality in the Sylvian fissure, go back and check for the right occipital fissure. The indentation for a 24-weeker is slightly less. It appears slightly hypomature for a 24-week scan. There is colpocephaly. This is the transventricular plane. There is colpocephaly, the preferential dilatation of the occipital horns. Again, this is the transventricular plane. Again, you are seeing the third ventricle is slightly prominent and high riding. So once you have findings in the axial plane, you need to go and see or extend into an extended neurosonogram, a full detailed neurosonogram. And this is the coronal sweep. Coronal sweep includes right from the frontal region, right up to the transcerebellar view. This is the Sylvian fissure. This is a transcaudate plane, the Sylvian fissure. Normally, you would expect to see an angle. It's at right angle or up to less than 20 degree. This is slightly more. The angle formed by the superior lip or the superior portion. Definitely abnormally shaped cavum septi pellucidum. The lateral walls are not parallel to each other. There's a tilt of the near field lateral wall of the cavum. So that is also abnormal. In the transthalamic plane, we see the typical or the shape of the lateral ventricles. So you need to go for the sagittal view. The baby was in a breech presentation, so direct visualization of the mid-sagittal view was undertaken. Shaped vermis, suggesting it's a mid-sagittal view. Also, you can see the glistening or the shiny, hyper-reflective falx over here. You can barely see a small portion of the corpus callosum over there. Actually, we see the corpus callosum as a nice, thick, black band of tissue or a bridge between both cerebral hemispheres. Here we see a small little black area over here. It's more echogenic, in fact, and it's very small. Again, another mid-sagittal view, the glistening falx seen along with the vermis. Again, it's a slightly more echogenic corpus callosum, which is small, slightly appears dysgenetic with a thin black band in between. So even the Doppler showed only the anterior portion of the body and a bit of the genu was, there was an interruption of the pericallosal artery sweep. Only a small portion in the anterior aspect of the corpus callosum was getting covered by the pericallosal artery, thus raising a suspicion of partial agenesis of corpus callosum. Now, the biometry was normal for age. For a 24-weeker, the HC was 56 centile on a Hadlock chart. And so the baby was since then lost for follow-up, and postnatally, we had contacted the baby telephonically. Now the baby is delivered 40 days old. That was a full-term normal vaginal delivery, 2.7 kg, healthy male baby, otherwise healthy externally. And in a routine pediatric assessment, nothing was found. And baby has been posted for MRI for a complete MRI evaluation for next week. So this is the story so far, sir. And now it's over to Ramoti, sir, to take over.
Are you able to see my screen, participants?
Yes, sir.
Yes, sir. Is my arrow moving around?
Yes, sir.
Yes, sir. Yeah, at the outset, I must thank Dr. Meenu and Dr. Bijoy for having organized this wonderful evening for us through the SFM Kerala chapter. We've just heard Dr. John giving us a good imaging walkthrough through an abnormal brain, and he's told us all the findings. So we will come down and discuss a few of these points as to the diagnostic aspects, as well as the dilemmas in counseling, right? And to help me do this, we have a wonderful set of panelists. We have Dr. Shagun Agarwal. She's an obstetrician gynecologist with a DM from in medical genetics from SDPI Lucknow. Works as an associate professor in the Department of Medical Genetics in Nizam's Institute of Medical Sciences, and also an adjunct scientist at CDFD, Hyderabad, and her interests are clinical dysmorphology and skeletal dysplasias. Dr. Boban Abraham works as a consultant in the fetal medicine department at Kraft Hospital and Research Center, Kodangalur, Chichur. And of course, he's finished his fellowship in fetal medicine from Mediscan Systems, Chennai. Dr. Mohit Shah is the vice president of the Society of Fetal Medicine. His interests are high risk of medicine. He is a consultant at Surya Mother and Care Hospital, Mumbai, and also works in his own center, Aviprai Center for Advanced Ultrasound Guided Interventions and Genetic Clinic in Mumbai. Dr. Swapnil Patil works as a fetal-maternal consultant at Simar Edapur for the last 5 years. Right. With this prelude, I thank Dr. John for sharing his case with us. Now, I've got a couple of questions to you, Dr. John, before we let you off. What were the findings in the mid-trimester axial ultrasound images that actually prompted you to look at the non-axial sections? You showed us coronal, you showed us sagittal, but what were the features that prompted you that you should do more? You should look beyond the axial sections. Can you tell us your thoughts?
First was the borderline to mild ventriculomegaly, which was clearly seen. There was a definitely abnormal cavum septae pellucidii size, shape, and the symmetry. The walls of the CSP was abnormal. And also there was some evidence of mild abnormal sulcation or sulcal data, which we needs to follow up in the further scans. These were the reasons why I extended my axial study.
Wonderful. The moral of the story is that any abnormal finding on the axial section is an indication to look beyond axial sections. And when you look beyond axial sections, you're talking of a study called a detailed neurosonogram. Now, in Dr. John's case, it was 3 different findings which were telling us to look for more, and that is why he did the neurosonogram. Now, what are the means, Dr. John, are there for performing a detailed neurosonogram? How would you, what is the hardware that you have on hand? What is the wherewithal that you have in your hand to say that, okay, this is how I'm going to do the
fundamental rule of ultrasound is just better the resolution, better the image quality, and better the diagnostic yield that we have. So if the baby is in vertex presentation, using a high resolution transvaginal transducer will be the most ideal way to perform a complete detailed fetal neurosonogram. And if the baby is in breech or in transverse lie, we need to use the best transducer available based on maternal habitus, baby's position also, using the transabdominal approach. And of course, 3D or 4D 3D reconstructions also surely do help, both axial, sagittal, and coronal reconstructions, which can be used both transabdominally and TTTS. These are the forms that we, the roots of evaluating the fetal brain that we commonly use. And the planes, as you asked, the external planes that we usually use is the coronal planes and the sagittal planes. The coronal planes would include right from anterior transfrontal, transcaudate, transthalamic, and the transcerebellar views, the 4 typical named views. Of course, we need to take a good, nice sweep right from the frontal cortex till the occiput. And of course, in the sagittal planes, the mid-sag view and the parasagittal views through both ventricles on either sides. So these are the rough additional planes and the routes that we usually use to extend our detailed scans.
Wonderful. So you spoke about the frequency. You always go for the highest frequency possible. And also the other fact is that you've got to get as close to the head as possible. Closer to to the head, better are your images. And nothing can get closer to the fetal head than the tip of a transvaginal probe when the fetal head is down in the vertex.
Yes,
when it's down in the lower pole of the uterus. Right. Now, Dr. John, again, what if the gestational age in your case example that you showed us was 21 weeks instead of 24 weeks? Would your interpretation be any different from what you actually took us through?
As far as the corpus callosum per se is concerned, there might not be a very significant difference between 21 weeks and 24 weeks. By 22 weeks, the entirety of the corpus callosum can be nicely imaged either by transvaginal or transabdominal route. While the sulcal aspect of it, that can significantly vary between 21 weeks to 24 weeks, and further on in pregnancy too. As the baby grows, as the gestational age increases, we get more sulcation, and the sulcal evaluation or sulcal delay, as you want to evaluate for, is best evaluated as the baby grows, and more so if it is in the baby is in the 3rd trimester. So that would be a differentiating point between 21 and 24 weeks.
So in other words, to rephrase your answer, I would say that at 21 weeks, your observation about the sylvian fissure and observation about the parieto-occipital sulcus could well be normal. Is that right?
Yes, sir. Yes, sir.
Absolutely. Absolutely. And that is how the fetal brain differs from the fetal heart. You know, every week, every 2 weeks, the appearance of the fetal brain continuously evolves in utero. And that is why a 21-week brain is not the same as a 26 or 24 or a 28-week brain. And it's a very, very important message that we have to take across. Okay, now we move on to Dr. Boban Abraham. There are 3 axial planes of the fetal cranium that are included in the mid-trimester anomaly scan: the transventricular, the thalamic and the transcerebellar, which is the one structure that is seen on all three planes and should be documented in all three planes.
Sir, thank you for the question, sir. Am I audible?
Yeah, you are audible, Dr. Boban.
Okay, as sir told, there are three important planes. These are the screening three planes which we do for a fetal head when you do a mid-trimester anomaly scan. As you know here in the first image, that is the transventricular plane. You can nicely see the CSP, the choroid plexus, and the lateral and the posterior horn of the lateral ventricle. In the second image, you can nicely see it is a transthalamic plane where you can see the CSP, the midline falls, and the thalamus. In this plane, actually, we take the BPD and the HCG measurements. And the third image is basically the transcerebellar plane where you can see the CSP, the midline, and also the dumbbell-shaped cerebellum and also cisterna magna. When you see all these three images, all these axial images, one thing which is common, that is the cavum septum pellucidum, which is very important. You have to appreciate and document it when you do a mid-trimester anomaly scan.
Oh, thank you, Dr. Boban. So we realized that cavum septum pellucidum actually gives us three chances to be documented in our routine studies. Three times it asks us to study. And in three planes, it asks us to see. So cavum septum pellucidum must be documented, must be studied, and must be looked at with some kind of a time element given to it to see whether it is normal or abnormal, right?
Yes,
okay,
sir.
now that it's so important, we realize that it's so important. Dr. Boban, can you describe how a normal cavum septum pellucidum looks in the axial sections?
In the axial section, the cavum septum pellucidum looks like a rectangular box, as you nicely see here. It is located in the midline. It is more towards the frontal bones, and also it is interrupting the midline falls. When you take the borders, you know that the anterior horns of the lateral ventricle form the lateral border of the CSP. Anterior part is formed by the genu or the corpus callosum. As you know, there are four parts of the corpus callosum: the rostrum, genu, body, and the spleen. So the genu is actually the anterior, forms the anterior border of the corpus callosum, and obviously the posterior part, which is actually the fornical columns. So this structure is very nicely appreciated in a mid-trimester scan. And when you take if you take the length to the breadth, it is actually, the ratio is 1.5:1.
Okay, so it's a simple thing to look at. It's a rectangular box which contains fluid, right? And it has the anterior horns on either side. In fact, a cavum septum pellucidum can be called a cavum septum pellucidum only if it shows you the immediate relationship to the anterior horns on either side. If the anterior horns are away from it, are not touching it, or not immediately adjacent, then it may not even be a cavum septum pellucidum. We'll come to that a little later. Now we will move on to Dr. Swapnil Patil, and we will ask him, why is CSP so important? Why have we been going through the CSP all the while?
Yes, sir. So CSP, because it shares a common embryo callosum. Basically the septal leaflets are formed by cavitations of the medial commissures, which is formed during the formation of the corpus callosum, and hence when the CSP is present, it indirectly denotes that the corpus callosum would be present. Secondarily, the CSP is part of the axial planes, the three basic axial planes which are reproducibly easily obtainable. Whereas the CC is part of the mid-sagittal plane, and it may be difficult to obtain. It depends on the fetal position, and hence when the CSP is present, it indirectly denotes that the CC would most of the time be normal, and hence that is the importance of CSP in a targeted screening.
Wonderful. Thank you. Thank you so much. So what Dr. Patil tells us is that if there's a normal CSP, mark my words, if there's a normal CSP, which you see in an axial section, you do not have to go around and go to the mid-sagittal section to prove that your CC is normal. You can let go of, because a normal CSP in the axial section is a surrogate marker for the presence of a normal CC in a mid-sagittal section. I think that is why those sections which show you the CSP in the axial plane are so very important, because it obviates the need of doing a mid-sagittal section on a screening basis. You do it only on a selective basis. So therefore, that is why CSP is so very important. Dr. Swapnil, continuing with you, can you tell us what are the structures that could actually mimic a CSP, although they are not they are not the CSP?
Yes, sir. So in the first image is basically the columns of fornices, which can be mistakenly reported as a CSP. It's basically distinguishable from the CSP by a 3 echogenic line present in the region of CSP. Basically, the columns of fornices forms the floor and the posterior part of the CSP. CSP is basically a box-shaped structure which is anechoic in echogenicity. In the second picture that you see, it's basically an elevated third ventricle, which is obviously a very common finding in agenesis of corpus callosum. The thing to differentiate elevated third ventricle from the CSP, it's its position. It's much caudally placed as compared to a normal CSP, which would be much anteriorly placed.
Fantastic. So the two major pitfalls, as he said, is the columns of the fornix. But if it's the columns of the fornix, we realize that the midline cuts through. It is not interrupted, whereas in a CSP, it is interrupted. The midline is interrupted. If you have the midline continuing through, that's not the CSP. Those are possibly the fornicial columns that you see here. So that's how you get rid of this pitfall. Whereas here, as Dr. Swapnil rightly pointed out, this is the overriding or extension, cephalad extension of the third ventricle, seen at the level of the lateral ventricle, and this is bang central, whereas the CSP is more towards the frontal aspect over here. Right, now Dr. Swapnil Patil, what is this concept of anterior complex? CSP we've understood, but suddenly there's another term which is called anterior complex. Could you throw some light on the concept of anterior complex?
So to overcome the pitfalls which you saw in the two above cases, it's very important to note the landmarks of the anterior complex. Anterior complex is basically the anterior part of the axial section of the brain. It's characterized by a midline interhemispheric fissure, which is interrupted by a callosal sulcus. Callosal sulcus of the genu of the corpus callosum. The genu is basically the anterior border of the cavum septum pellucidum, and the lateral borders of the CSP is formed by the converging leaflet, converging medial wall of the anterior fornix of the lateral ventricle. Now, the two most important structures here is to mention here is the shape and size of the CSP and the convergence of the medial wall of the anterior fornices of the lateral ventricle. These two landmarks will help you and are key to guide you in the diagnosis of callosal agenesis.
Okay, so it's basically the CSP itself and its immediate neighbors that they have added to call it the anterior complex, correct? So there's also a posterior complex, but we won't go through it at this point of time, right? Now, to summarize, presence of a CSP in an axial section, a good, nice, normal, vibrant CSP means that you're assured that there's a nice, normal corpus callosum which is seen in the mid-sagittal section, if you were to do a mid-sagittal section, which you don't do normally if there's a normal CSP. We move on now to Dr. Mohit Shah. And Dr. Mohit, can you tell us what is the relationship between an abnormal CSP and corpus callosum?
Just to reiterate the fact that the development of corpus, the cavum septum is directly related and dependent on the development of corpus callosum. So what it means is if you see a normal CSP, it indirectly implies a presence of a normal corpus callosum in the mid-sag. That's normal. The CSP will always be absent when the corpus callosum is absent in the complete agenesis of corpus callosum. But if you see that the corpus callosum is nice and present, but the cavum septum pellucidum is absent, this can happen in septal agenesis. But the vice versa is not true. I mean, you will never have a scenario where the cavum septum pellucidum is present and normal, but the corpus callosum is absent. Also, a point to notice that the length of the cavum septum pellucidum is directly proportional to the length of corpus callosum. And this is a point to note in cases of partial agenesis of corpus callosum or callosal dysgenesis. If the corpus callosum is smaller in length, it will reflect in the size of the cavum septum pellucidum. So therefore, the cavum septum pellucidum serves as a surrogate marker to gauge the abnormalities of corpus callosum.
Thank you, Dr. Mohit. So we said that a normal corpus CSP would translate to a normal CC. In the same way, the equation also holds good for an abnormal CSP translating into an abnormal CC, and we will look at a few situations here. Now, quickly, I will take you across colpocephaly, pointed lateral anterior horn of the lateral ventricle, far away from the midline, absent cavum septum pellucidum, the 3-line sign seen over here, 3-line sign seen there. And when you do a mid-sagittal section, that's the vermis, that's the fox, which is the rich texture. There is no corpus callosum at all. So an absent CSP, a totally absent CSP, translating into an absent corpus callosum, a complete absence of corpus callosum. On the other hand here, this is an axial section. You have the anterior horns on either side, but the anterior horns seem to be running into each other. You simply don't see those two lines here, which bring to you the rectangular box. Those lateral lines are missing. Now that is septal agenesis, and this is one situation where there's a dichotomy. The cavum septum pellucidum is absent, but yet the corpus callosum is present. As you can see here, in the same case, the corpus callosum is brilliantly seen as a nice, normal-looking hypoechoic band with two hyperechoic borders on either side throughout its entire extent, right? So that is the normal corpus callosum in spite of a CSP which is missing, and you call it a septal agenesis. We look for the optic chiasma, and if the optic chiasma is present, more or less we are thinking in terms of an isolated septal agenesis and not septo-optic dysplasia. But in this case, there is a surprise which is there. I've marked 25 weeks over here. This is a 25-weeker, and you see the kind of parieto-occipital sulcus. The parieto-occipital sulcus is very shallow, and this is certainly for 25 weeks. This is a very, very delayed or immature form of the sylvian fissure, and therefore there is also a good chance that there's going to be lissencephaly over here. So therefore this is a septal agenesis plus lissencephaly which is happening over here. Now, can I ask Dr. Mohit to take us through the 3 examples which are seen here, 3 examples of corpus CSP and how they translate into the corpus callosum when you do a mid-sagittal section.
We all don't need to measure the CSP objectively in each and every case. If you train your eyes and brain to look at the anterior complex in each and every patient, a simple eyeballing will tell you that the CSP in the first image, the left top corner, instead of a rectangle boss, you see a square. So that means that this CSP definitely is abnormal. And when you see that in a sag plane, you see that the corpus callosum is extremely short and thick. It should be overhanging the tectum of the midbrain. You see that the corpus callosum is short there, stopping there. You don't see the rostrum, you don't see the splenium, but you see a very short and thick corpus callosum. So that is a definite sign of a callosal dysgenesis. In the second case, you see that the rectangle that you see on eyeballing looks much smaller and is slightly obliquely oriented than in parallel to the interhemispheric fissure. So you do that in mid-sagittal, you again note the absence of the rostrum as well as the splenium. A point that you need to always see in mid-sag plane is, does the corpus callosum extend to overlie the tectum of the midbrain? If it does not, then we know that the splenium is absent, and this is a classical case of PACC. In the third case, you see a rectangle, but it is not oriented longitudinally. In fact, it is placed horizontally. So it's a classical abnormal CSP. Again, when you see it in the sag plane, you hardly see an corpus callosum. It's extremely thinned out, a classical corpus callosal hypoplasia or dysgenesis, as you would call it. So an eyeballing of a CSP in each and every case will help you determine whether the CSP looks normal for the gestational age, and therefore you can translate it to mid-sagittal corpus callosal abnormalities.
Thank you, Dr. Mohit. Just to add another point, if you want to objectify, you can measure the callosal length from the anterior aspect of the genu to the last posterior outer aspect of the posterior limit. And you have nomograms to support you on what is normal and what is abnormal.
Same goes for the thickness as well.
Yes, and also the thickness as well. You will find that this is abnormally thick, whereas this is abnormally thin. Right. So we move on to another very, very important aspect. Now, once a partial agenesis of corpus callosum is diagnosed, what is the next step, Dr. Mohit?
Like in any case in any other system, if you pick up one abnormality, you have to look for abnormalities in other system. So the problem with PACC is, if you pick it up at 20 weeks, as you rightly said, it becomes very difficult to say it is isolated because we don't know the status of sulci and gyri at that point in time. But what we can actually note is whether we see any abnormality anywhere else in the fetal brain, because they have a 46% chance of having other brain abnormalities. They have an association with chromosomal abnormalities, almost 18%. So you look at the other structures quite well. And knowing that you can have an associated sulcal abnormalities coming in, we got to know that even 15% of isolated lesions postnatally had other anomalies. So invasive testing in the form of CMA and exome is advisable. And what is more advisable is to store the DNA if you have picked it up quite early.
Okay, thank you. So it means to say that you look at the brain carefully, do a neurosonogram, maybe even look at MRI. We'll come to the issue of MRI later. You do look beyond the brain and look at the rest of the fetus, do a good TIFA scan, and then of course invasive. So we will come to these issues a little later, and DNA storage, right? So now here is the article which tells us about the 18% and the 46%. This is a meta-analysis 2012. We've got to realize that this is the pre-CMA era. You know, there was no CMA at that point of time. Now I'll go back to Dr. Boban Abraham, and I'll ask him, we expect a lot of other brain anomalies which are associated with corpus callosal agenesis, complete or partial. What are these kind of anomalies? Can you throw some light on what are you going to churn in your brain as you do the detailed neurosonogram? What are the lesions which cross your brain when you look at the brain in terms of detailed neurosonogram?
So if you have a suspected PACC or a complete ACC, we have to look into other brain abnormalities, especially the gyration abnormalities. For example, the lesion-Kephili, we call it as smooth brain, or you have to look at the polymicrogyria, or you have to look at the heterotropia, like periventricular nodular heterotropia, or you can even look at the cerebellar cleft, any asymmetry of the cerebellar hemispheres in form of cleft or split, like for example, Reisen-Kephili, or a Dandy-Walker malformation or complex. So all these will definitely prognosticate the the incidence of this particular ACC, either it is partial or complete. And definitely, when you do the other microarray and other genetic testing, that will also add it to the prognosis of this fetus.
Oh, thank you so much indeed. Now, I just have to remind that if you find other intracranial abnormalities together with a partial agenesis of corpus callosum, you call it a complex PACC. So you have a isolated PACC, complex PACC, and we will go on to see how there is another entity called a syndromic PACC. Now, I come back to you, Dr. Bob. Now, why do you want to do an MRI? If at all you want to do an MRI, why do you want to do an MRI?
Now, as said, if you have a suspicion of a complete or a partial ACC, definitely you have to confirm it. You need an MRI, because MRI is an additional modality apart from an ultrasound. So MRI will definitely tell you about the confirmation of the ultrasound, and also to rule out any other additional findings which I have mentioned right now, like especially the gyration, the sulcation, and also other findings. So it is actually indicated in a case of a suspected or confirmed PACC or CACC. So when to do an MRI? So once you have a confirmed diagnosis, depends upon many factors, like for example, depending upon the gestational age of the fetus, depending upon which modality or high resolution images which you got, or you have done a good neurosonogram as per the ICOG guidelines. If you are confident about your findings, that is a complete or a partial, definitely, and she is almost around 26 to 28 weeks, we can definitely advise for a fetal MRI, especially to confirm it, as I said, and also to look for other additional findings as mentioned earlier. So definitely, and also depending upon the patient, we have to counsel the patient accordingly, because the findings, if you find it much earlier, because we have to literally tell them, even if it is isolated, there are other possible brain abnormalities which can be picked up much later. So that also, that information has to be carried out when you see an isolated, the so-called isolated of a partial or a complete, when you scan her at around 21, 22 weeks. Literally have to wait for around 26 to 28 weeks. At fetal MRI, definitely it lags by 2 weeks when compared to an ultrasound as well. So 28 weeks is much ideal time to do a fetal MRI.
Okay, so the idea of doing an MRI late, it doesn't mean you don't do a repeat ultrasound. I always do a repeat ultrasound with the MRI if the couple decides to go on and see what else is in store. This 28 weeks or 26 weeks is given because you want the brain to develop in terms of its sulcation and gyration. To a certain extent, that you have a handle saying that it's normal or abnormal. And remember, we also have to give into the fact that MRI might add about 12% more cases of findings, additional findings, right? But this 12% will fall considerably with the increase in the quality of the neurosonogram. So therefore, if you've done an excellent neurosonogram and your pictures are brilliantly produced, the chance of an MRI adding an additional finding quantumly drops. So that's very, very important to understand, that we've got to exploit ultrasound fully until you look beyond it, right? Now we go back to Dr. Swapnil Patil. What about the extrarenal, extracranial anomalies? We've seen intracranial. What about extracranial anomalies?
Yes, sir. It's very important to rule out extracranial abnormalities, because any associations or syndromic associations with callosal agenesis would obviously give it a very bad prognosis. So it's important to do a target scan, look at the heart, look at the limbs, look at the abdominal system, GI, GU system. The most common syndrome which is associated is obviously Aicardi syndrome. It's an X-linked dominant syndrome. So it involves only female fetuses. Characteristic lesions with this syndrome is interhemispheric cyst, facial dysmorphism, microophthalmia. There may be polydactyly, which is associated with acrocallosal syndrome, facial dysmorphism along with skeletal abnormalities are commonly associated with orofacial digital syndrome. It's even important to look for signs of infections, look at the liver, look at the GI system. So it's very important to rule out any extracranial abnormalities to prognosticate a case of callosal agenesis.
I'm happy you spoke about X-linked dominant. That brings us to the fact that in any of these cases, I would silently look at the fetal perineum. I would say, I'm not going to announce it in the report. I'm not going to share it with the couple. But I know if I'm suspecting an Aicardi syndrome, say suppose I've seen a complete agenesis or a partial agenesis of corpus callosum, I've seen a couple of hemivertebrae, and I'm strongly thinking that this is an Aicardi syndrome, I quickly go to the perineum and see. If it's a male fetus, that it cannot be Aicardi, because Aicardi syndrome is X-linked dominant, and in a male, it is embryonic lethality. So therefore, if it's a male perineum, I would say, okay, no, may not be Aicardi really, right? So you can, looking at the fetal perineum, looking at the combo of findings, you can fairly be predictive of what is the kind of syndrome that you're dealing with, right? Now we come to the last leg of this presentation, and that is where Dr. Shagun Agarwal steps in. Now we've finished with imaging. What are the other indications that are indicated? What are the other investigations that are indicated? Dr. Shagun, please.
Yes, so now that like we have done the imaging, so one thing first we need to, before we move on to actually genetic testing, one thing which we need to really rule out first is any evidence of infection. So maybe guided by the scan findings, or sometimes even if there is an isolated finding of a corpus callosum agenesis, we would still do a basic simple maternal torch serology, because both rubella and CMV infections are known to present with corpus callosum agenesis. And besides this, of course, in all such cases, it is very important to do invasive sampling and go ahead with genetic testing. But then there are more than 200 genetic syndromes. I mean, some of them which we have already briefly discussed, but many, many more due to various causes. Either they could be chromosomal aneuploidies or submicroscopic chromosomal abnormalities or single gene disorders. So various types of genetic etiologies can present with a partial corpus callosum agenesis on ultrasound. So I would really need to first actually look at the family. So I would take a 3-generation pedigree of the family, try to look at things like, is there any history of male lethality, which would point me towards the possibility of Aicardi. So if the lady had previous all abortuses or second trimester losses and all of them being males, then I would think this could be Aicardi. Similarly, any other suggestive family history. So that would help us in guiding the genetic evaluation, what type of genetic test we would do. And of course, any findings of the serum screening reports, other extracranial cranial findings. So all this I would take into account before I would say that this is the particular test that we should be doing for this patient. So, I think we can discuss accordingly. So, so if we have this information available, so we could take up this further.
Yeah. Thank you, Dr. Shagun. And let us look at one of two cases, the first of the two cases that we will use to illustrate the implications of genetic testing. Now, the first case I'm going to share with you is that's the LMP. This has a normal 5-year-old. There is no history of consanguinity. This is her second pregnancy, and she presents with a thick NT 3 millimeters. Combined test trisomy 21 risk is 1 in 1842, not an issue here, but the trisomy 13 risk is 1 in 130. She's 12 weeks gestational age, and because of this trisomy risk being 1 in 130, an NIPT was planned, and the NIPT gives us a fetal fraction of 6%, and there is a suspected trisomy 13. So not only does the combined test suspect trisomy 13, it is also the NIPT which has further fueled this suspicion. And with this happening, we are going to plan an invasive testing. Now, when we plan an invasive testing, the issue is trisomy 13. So you have two options. You can do a karyotype, or you can do a chromosomal microarray. Now, I go back to you, come back to you, Dr. Shagun. Tell us which one would you prefer to do, a KT or a CMA, and why?
Okay, so basically here, although we have a combined test and an NIPT, both telling us that this is an increased risk for trisomy 13. But then even in such a scenario, we would prefer to do a chromosomal microarray. And we already have sufficient evidence in literature. And this is one very beautiful study in 2012, where they have studied more than 4,000 babies, done parallel karyotype and microarray. And what they found was that even in 1.7% of pregnancies, where actually the indication of doing the invasive testing was not a structural anomaly, but it was either an advanced maternal age or a positive aneuploidy screening like we have here. Even in those babies with the scan looking normal, actually like 1.7% of those babies had a copy number defect, which is basically a submicroscopic chromosomal abnormality which will not be seen on karyotype and can only be picked on microarray. And of course, in presence of a structural anomaly, and here like we also have an increased NT in this case. So increased NT also per se, as well as if there was a structural anomaly. So this as such has an increased yield of chromosomal microarray over and above a karyotype of around 6%. So with this information in mind, whenever we are offering invasive testing for whatever indication, here it being an increased NT and a positive screen for trisomy 13, or if it could be any other indication, we should always offer a microarray to the patient in view of this additional diagnostic yield.
Thank you very much. Now, we move on with the story of this patient. Amniocentesis was planned at around 16 weeks and 1 day. QFPCR normal for chromosome 13, 18, and 20. So the issue of chromosome 13 being in 3 copies is totally ruled out because QFPCR is okay. CMA was opted, and CMA throws up a surprise over here. There's a microdeletion in chromosome 6. Q14.3 to Q15, it's a 2.4 megabase pair loss, and it contains about 10 OMIM genes, right? The clinical significance, if any, of the genes listed in the context of the sample phenotype is unknown. And to just remind our participants, at the moment of time, the phenotype is, the clinical phenotype is a thick NT with CT and NIPT giving a high risk for 13. So with this kind of a phenotype, this deletion that we see here, micro deletion that we see here, does not correlate. Clinical correlation is recommended. And all this played out at around 16 weeks and 1 day. So since this is a variant of unknown significance at that point of time, the patient, the couple continued, and they came back for a these are the reports which tells us the same, right? They come back, they came back at 19 weeks plus 5 days for an anomaly scan. And in the anomaly scan, you see the unmistakably abnormal CSP. It's broader than longer. It's the rectangle in the other way around, not this way, but the other way. Right, I've got you the measurements as well, and therefore a detailed neurosonogram. And in the process of doing a detailed neurosonogram, you find that there's just hardly a bit of the anterior body here. There's nothing else of the corpus callosum, a very, very tiny bit of corpus callosum that you see here in the anterior body region. Even the genu is absent, rostrum is absent, posterior body, splenium, everything is absent. So now you have one more handle, which means that your phenotype has now changed. The phenotype of a thick NT has now changed to a phenotype of a partial callosal agenesis. Now at this stage, it's hard to look for malformations of cortical development because of the gestational age. There's no sulcation gyration that you expect to see. So I asked her to come back for a scan at 22 weeks just to make sure of this and then carry it on from there. But she opted for a TOP. And now I would like to bring back Dr. Shagun Agarwal and ask her to reinterpret. One interpretation is over. Now we have a new phenotype. Now, in the light of the new phenotype, can you tell us what this microdeletion would mean, Dr. Shagun?
So before we go on to that, I would just like to say that whenever we get back a microarray report, so there would be situations where we get an obvious positive finding. So there is no confusion, and there would be a situation where it comes back as normal. So there, of course, there is no confusion, and the decision can be taken based on the scan findings. But now here, what we had was a copy number of uncertain significance. So actually, whenever there is a situation like that, one thing I would suggest is that you should always, phone your friend, the geneticist, because sometimes there would be a lot of hidden information which would be still there in that report, which could help you in looking for additional things on the scan, and then correlating these the genetic information with the scan findings. And here now, as already we have now the scan findings at 19 weeks, and we have this additional phenotypic information of partial corpus callosum agenesis. So in the light of that, let's just take a look at what this deletion, is it really still uncertain, or can we reassign it to a positive result or a negative result? Positive as in something significant. So if we look, so this is an online kind of website where we can go, we can actually put the deletion there, and this red thing is the deletion. And what is of interest here is that in this deleted region, these two red things, what bars you can see, these are two genes, loss of which is known to be really significant. And of this, if we go on, if we look at this particular gene, that SYNCRIP, so we'll go to the next slide. So this particular gene, actually, there has been data available. So if we search, at additional genetic databases, we see it is very highly expressed in the fetal brain. And then there is study where other studies which say that this is a potential intellectual disability and autism gene. And then interestingly, there is already a paper of around 45 patients with a deletion in the same region, although majority of these patients had very big deletions. So they had other genes also involved. But interestingly, some of these patients had deletion of this gene also, and all of them had corpus callosum abnormalities, and all of them had developmental delays, some had seizures, autism. So now when we see, this is actually a perfect fit. We have a scan finding of corpus callosum agenesis. We know that deletions which involve this gene, which is really significant for brain development, is actually associated with corpus callosum agenesis. So this actually gives us the answer. This is not a variant of uncertain significance. With now correlating this genotype and the phenotype, we can now say that this is a pathogenic variant, and on basis of this, we can actually clearly counsel this patient that this is likely to be a poor prognosis case, and then they could actually take a decision for termination of pregnancy. And one more point here, what becomes important when we identify a genetic diagnosis. So here it is a copy number defect. So in such cases, usually recurrence risk will be low, unlike the single gene disorders where recurrence risk can be high. So here it's likely to be quite low, but still as a geneticist, I would advise some additional tests for the parents before I say that the recurrence risk is going to be low. So this is like a very beautiful case where we can actually really, we see how with additional phenotypic findings and with additional literature review and in-depth study of that particular copy number variant, we are actually able to arrive at the correct answer and give an accurate kind of prognosis to the patient.
Okay, so that changed the variant of uncertain or unknown significance to a likely pathogenic variant. So look at the ocean of a change, number one. And number two, what I'd like to share with our participants is that karyotype cannot detect microdeletions. And if we had done a karyotype instead of a CMA, we would have missed the 2.4 megabase pair deletion, microdeletion. Extremely important. It's a classical example to say that CMA yields that 6% more. And this is one such case which constitutes that 6%, right? So that's as far as the karyotypic, the chromosomal based anomalies go. Now we leave chromosomes and we'll come to single gene disorders. We are coming down into the genetic level. Now, the question I would ask Dr. Shagun is, when would you consider testing for a single gene disorder But before I hand over the mic to her, so to say, I would want to share this case scenario as a starting point. Now, here is a 23-year-old. The first pregnancy was a complete agenesis of corpus callosum. It was a male fetus, TOP done at 22 weeks. Now, G2 is her present pregnancy, and at 20 weeks, we find that the CSP is very, very tiny and small. There is upper normal 9.2 on one side and 7.8 on the other side as far as the lateral ventricles go. And then there's a hyperechoic midline structure that you see here that could be a lipoma. When I do my 3D reconstructions here, you find only the anterior portion of the corpus callosum, which is seen here, nothing beyond. So it's clearly a case of partial callosal agenesis. So that's the lipoma, that's the colpocephaly that's happening here. Now with this, you need to look for the extracranial abnormalities. And here I would want to play this clip to tell you that the hands, the facial dysmorphism, the genitalia, these are all the important things that we've got to rope into, narrow down our diagnosis. You have 4 fingers outstretched here, and you have the thumb going across, and this was persistent. If I were to use the bookmark here, I'll just take you to the bookmark, and those are the fingers outstretched, and this is the thumb inside. You know, it's this way. So the thumb was persistently adducted, and that actually strikes a chord. So once you see an adducted thumb, you think of an X-linked hydrocephalus. And if it's an X-linked hydrocephalus, it's an X-linked recessive disorder. It cannot express itself in the female because there are 2 X's, a healthy X and an X with a mutation, right? So the healthy X dominates, you will never get X-linked hydrocephalus in a female. So in an X-linked recessive disorder, it's the male fetus which actually bears the brunt, so to say. So you quickly go to the perineum and you find that this is a phallus, which looks like a penis, and therefore, and the scrotal sac is, there is no cleavage into the labial fold, so you know it's a male fetus. So everything has fallen into place, and you know that by ultrasound that you're really thinking of a syndrome called condition called X-linked hydrocephalus. It also is called the crash or the Massa syndrome, and the culprit gene is the L1 CAM gene mutation, which is seen on the short arm of X28, the region, the subregion there, right? So that ultrasound tells us a targeted, look, this is what I'm looking for. This is what I'm looking for. And this kind of an exercise is important. We need to pattern our findings towards a particular potential syndrome that we're dealing with, right? So therefore, this lady, of course, when we told her that she needs an exome sequencing, we need to look at the genes, she really declined invasive testing. And I also draw your attention to the fact that the first fetus with CACC also was a male. So that is where history taking also becomes so very, very important. Okay, now, Dr. Shagun, I now ask you to step in and tell us under what circumstances you will think of a genetic single gene disorder rather than a karyotypic or a chromosomal array-based disorder.
Right. So this, like the case, what we have seen here, this is a classical case. Like we have everything here. So we have a family history, previous male baby who has a corpus callosum agenesis. We have the scan findings, the adducted thumb, and presence of corpus callosum agenesis, although this is partial this time. But this kind of the family pedigree as well as the ultrasound findings. So everything is fitting into a specific known single gene disorder, which is because of mutations in this one gene, L1 CAM gene. So in such a situation, we know for sure that this is a single gene disorder. We even know about the inheritance pattern. So here it kind of becomes easier to directly offer them testing for a single gene condition. And we already know the particular gene. So again, what kind of test we offer would depend on the size of the gene. So if it is a small gene, like up to 10 exons or something, then we can do something called as a targeted gene sequencing or Sanger sequencing. But if it is a big gene, like for example, N1CAM, so this has around more than 20 exons. So in this case, the test of choice would be to go for exome sequencing. Clinical exome is what we offer in the for purpose of diagnostics. So for research basis, we could go for even higher other tests like whole exome or whole genome. But for clinical settings, a clinical exome is sufficient. So this is the test which would be using, because this is a huge gene. The same test we would be using, suppose we had a condition where we know multiple genes are involved. So like even if you made a diagnosis of suppose Walker-Warburg syndrome, so corpus callosum agenesis with hydrocephalus, cataract or other ophthalmic abnormality, you know this is Walker-Warburg. But we know Walker-Warburg is caused by mutations in around 8 genes. So then in that case, I cannot do Sanger sequencing. Again, I would be doing clinical exome sequencing. So what Ramurthy sir, what he emphasized just now, and which is very important, then when we look at the complete picture, we look at the family history, we look at the scan findings, intracranial, extracranial finding, and attempt to make a syndromic diagnosis at that point. So that, and then we can take a call whether we go for a microarray or is this an obvious single gene disorder, let us go for a single gene testing. And then the choice of testing would depend on some of the factors which I discussed just now. And then besides this, other situations where we could go for clinical exome sequencing, even if you don't have an apparent diagnosis on basis of your scan, is where you already have a positive family history. So you have a previous child who has similar findings, whose clinical course you are aware of to some extent. So then in such case, again, you are expecting this is a single gene disorder. So instead of going for a microarray, I would go for testing using clinical exome. If you have, so the second scenario we have already discussed, a monogenic syndrome with specific imaging findings. So you have a clinical diagnosis. Then also situations where you have multiple defects not fitting into any specific condition, or migration defects are there, Lissencephaly is there, CMA has come out normal, then the next step or a parallel step, I would say, to save time would be to do a clinical exome. And another scenario which is quite common in our country, especially southern part of our country, is consanguinity. So at least 30% of the population, at least in my catchment area, they are consanguineous actually. So in such situations, automatically there is an increased risk of autosomal recessive condition in the baby. So here again, I would offer to go for single gene testing by using clinical exome. And finally, I would say that even if nothing is there and you just have an apparently isolated agenesis of corpus callosum, you can still offer the patient clinical exome sequencing along with the microarray, because there would be some findings like we have already discussed, like the migration abnormalities, which will not be visible now, but which come later at 26 weeks, 28 weeks. By that time, it will be too late to take a call on the pregnancy. So for better prognostication, you could offer this actually to every patient, and so that you have a genetic diagnosis, and then depending on that, you could give an accurate prognosis. You can even tell them what is the recurrence risk for next pregnancy, and you can offer them an early prenatal testing by CVS in next pregnancy once you have a diagnosis in hand. And another interesting, another point which is important, which is same what happened in this case also, so the patient often decline invasive testing. Once we tell them poor prognosis, they don't want to do anything. They just go and terminate. But at this point, it is important that we liaise with the obstetrician and we try to get a sample for DNA of the baby. So the sample could just be the simplest thing which can be collected is a 5 centimeter of cord, umbilical cord, which anybody can collect. So just a 5 centimeter umbilical cord, you don't have to do anything, no skin biopsy, no intracardiac puncture, although that is a preferred sample. A skin biopsy intracardiac puncture is preferred, but many times the obstetrician is not able to do it. So simple thing you can tell, just 5 centimeter of cord, umbilical cord. If they bring in normal saline, the DNA can be extracted, and when the patient is ready, we can go for a clinical exome sequencing so that we can help them for the next pregnancy. And of course, fetal autopsy is very important, because you would find some dysmorphism, additional findings in at least 25% cases, actually even sometimes more. You may find what is looking on scan as apparently isolated actually is part of a syndrome, so which you would be able to see if you do an autopsy. So this would help also you help in guiding what genetic test to do as a next step.
Okay, now again, Dr. Swapnil Patil, how would you define isolated? Can you define what is isolated in terms of the fetus as it is in utero in a pregnancy which is ongoing?
So to define corpus callosal agenesis as isolated is very important, basically for counseling. And hello.
Yes, you're audible. You're audible, Dr. Patil.
Sorry, sir. So it's basically important to prognosticate the cases. So to define it as isolated, everything has to be normal antenatally. Everything, I mean to say, it's there should be no intracranial findings. So at the diagnosis, your neurosonogram should be normal. The MRI should be normal. It's important to do follow-up neurosonograms every 1 month. MRI to be done in the third trimester of pregnancy to rule out developing migration disorders. Extracranial finding has to be sought out by doing a targeted scan. Any evidence of infection has to be found out with scan and doing TORCH screening. Any genetic abnormalities, chromosomal abnormalities to be ruled out by doing chromosome microarray. And if the chromosomal microarray is normal, but still there is strong suspicion of single gene disorders, as mentioned in all those indications in the previous slide, don't hesitate to do an exome sequencing, preferably a clinical exome. Having said all that, there is still 15% chance that the baby might be abnormal at birth. So even postnatally, it's important to evaluate the baby by doing clinical imaging and extensive clinical examination to say that it is truly isolated. And it's always important to counsel all this in the prenatal period so that there should be no surprise to the parents as to prognostication of this case.
Okay, thank you, Dr. Patil. Now we go back to Dr. Shagun and prognostication, and here is the crunch. And this is why this issue of corpus callosal agenesis, partial or complete, has been brought into this particular evening, saying that there is going to be a dilemma, there is going to be an equipoise, there's going to be a problem. And Dr. Shagun, can you tell us, as regards to sitting and talking with our couples who have a fetus with such a lesion, how would you actually go ahead and triage these fetuses, so to say that counseling is easy here, counseling is tough here? Please go ahead.
Sorry, sir.
So,
if we
so
can
once we are able to
next, 5 minutes or so.
Yes, that's it. We don't. I don't think we need 5 minutes. Also, I think we'll wind up much before that. Dr. Shagun, please.
Yeah, so once we have a complex PACC or a syndromic PACC, there is obviously going to be a poorer prognosis. So this is easy. So once you have this, you've made a diagnosis in this particular part, so then you can easily counsel them that the prognosis is likely to be poor, and then they could take a decision accordingly. Whereas if you have an isolated PACC, so you did a scan, neurosonogram, you did an MRI, and it's still isolated, you did genetic testing, karyotype is normal, and if you did a microarray or exome, so depending on the results, if everything looks normal, still there remains a challenge actually in counseling these patients, because as Dr. Swapnil said, at least 15% of them would have additional postnatal findings also. So if we look, how we could counsel is that we could actually just take a look at empirical data from literature. So we have this very beautiful meta-analysis in 2012, where they have actually taken 132 fetuses with an apparently isolated corpus callosum agenesis and seen the outcome. And then we see that around 70% of these babies would actually be normal. Whereas we would have at least around 30% of the babies going to have various degrees of disability. And if we try to look at a sub-analysis, we see that for an apparently isolated PACC, actually, the figure of normal is actually 5% lower. So actually, it is somewhat worse than having a complete corpus callosum agenesis. So here, at least 27% of the babies would have a severe disability. A severe disability means that you cannot even train them for basic daily tasks. So which is like very significant, and even around 7% would have a borderline to moderate disability, where they could be trained for basic tasks and some basic schooling, but not beyond that. And in addition, what is hidden in these figures is that many of these children could have other issues which don't get counted as an intellectual disability, which is like in form of autism, behavioral abnormalities, sometimes coordination difficulties, speech delays, some learning disability which does not get categorized as intellectual disability. So there are still a lot of issues, and so this counseling kind of becomes really challenging here. Only thing what we need to remember is that these figures are the kind of pre-array figures. So this is on basis of a normal karyotype, a normal neurosonogram, and a normal MRI whenever it is done. So then you have these figures. But now that we have availability of microarray exome sequencing, so we in a particular patient can actually use this genetic test and further refine this risk. So if those results come normal, so some of these cases of the disability ones will actually move into the cases where you would find something, so you would have a clear answer there. So these figures would become lower once we are able to integrate everything together, the scan, the MRI, and the genetic test, depending on the indication.
Thank you, Dr. Shagun. But from the couple point of view, for example, in an apparently isolated PACC, I would say that there is a 65% chance of your baby being normal and a 30% chance of it being severely disabled. But I don't know your particular baby, whether it fits into this group or this group. And that is heart-rending, and that is the equipoise. That is something which we cannot resolve as on today. Right, so that is as far as PACC is concerned. For CACC, it's a little better. You know, you have 83% on one side, which can go on to be normal, and about 16% with some disability, notwithstanding all these disorders which Dr. Shagun took us through. So therefore, that is heartrending. And that uncertainty most often drives a couple to take the extreme decision of a termination of pregnancy. And that is why this is a challenge. It will continue being a challenge until we find some very, very penetrating answers in the future, right? So in conclusion, study and document of the anterior complex is essential in mid-trimester anomaly scans. If mid-trimester anomaly scan is done around 18 weeks and good images of the anterior complex are not forthcoming, I strongly recommend you to do a repeat study at 22 weeks, extremely important. Any doubt on axial section should prompt a detailed multiplanar neurosonogram. All intracranial and extracranial findings are collated for patterning. All efforts to brand CACC and PACC as isolated should be done. And geneticist's opinion, which is a 3-generation pedigree chart, testing strategy, interpretation of results. Which lab are you going to send? What are you going to ask? What are the results which are expected? Who is going to interpret the results? All this is in the realm of the geneticist, a very, very crucial link in the delivery of the healthcare to the fetus. CACC and PACC worked up with CMA as a starting, and plus ask for a DNA storage. And in case single gene syndromes are suspected, you have the stored DNA to fall back on and to do an exome sequencing. Counseling in isolated cases, as we've seen, is challenging. So I take this opportunity to thank our hosts, Dr. Meenu and Dr. Bijoy, for hosting us. It's been very late. We still have about 200 odd brave hearts with us, in spite of it being so late. And I take this opportunity to thank all my panelists for a wonderful, brilliant session. Thank you so much indeed. Thank you. Bye-bye.
Thank you. Thank you. Good night. Thank you.
Thank you, sir. And I think before we end, let me thank each and every one of you. We had more than 500 delegates today.
Yeah.
It was excellent. I have to thank the entire faculty, all the teachers who took all this time and were so patient enough today to sit back and teach each and every one of us. I also thank all the sponsors. I have to thank Vishal, who is always there at the back end managing everything, and Conferences International. And lastly, I think hats off to Ashok sir and Praveen sir, because they're always there behind motivating us to perform even better and better. Thank you so much. Thank you, everyone. And good night.
Good night.
Good night. Bye-bye.
Good night.
Bye. All of you all. Bye. Bye.
Night.
Good night.
Right.
Good night.